Good morning. I'm Alan Jetty, and I have the pleasure to welcome you today to our conference, New Frontiers in Disability-Related Comparative Effectiveness Research. I'm really delighted to have so many of you here. Appreciate you all taking the time to come to this beautiful weather in Boston we've been having the past few days. Many of you are from out of town, so we're blaming you for bringing this weather. I want to begin by thanking several people and organizations, and I want to begin by thanking the Boston Red Sox organization. We had promised an exciting, positive game, and the Red Sox, although it was dicey at times, they did in the end deliver. Yes, no pun intended. I also want to start out by thanking all the speakers who are with us today. I really appreciate your taking the time out of your busy schedules so that you could be here and really help us make this what we hope to be a first of future conferences a great success. I also want to welcome all who are with us today through webcasting. Many could not be here in person, and we're delighted that several hundreds of people are with us through webcasting technology, and we're delighted to have you with us today as well. There are a lot of thank yous here, so give me a moment. I also want to thank the staff of the Health and Disability Research Institute at the Boston University School of Public Health. They have done an outstanding job of pulling this conference together. They really they went above and beyond the call of duty to really make sure everything was put together in a way that made it easy for our speakers, for our audience, and for all of you who are here with us through the webcasting. Particularly, I want to single out Mary Slavin and Molly Marino, who really took the lead and just provided outstanding leadership in putting this together. We've done many conferences over the years. We've learned how to do this, and I think it really showed in the work that they did, along with all the other staff of the Health and Disability Research Institute. So thank you. I also want to acknowledge that our partners in this is the opportunity for doing this conference came about because we at Boston University have one of the R24 Research Infrastructure Center grants, which are funded by the National Center for Medical Rehabilitation Research at NIH. And it really gave us a wonderful opportunity to team up with two other of the R24 infrastructure centers who have co-sponsored this. And the first I want to acknowledge is Ken Ottenbacher, who directs the Center for Rehabilitation Research using large data sets at the University of Texas Galveston branch. So Ken, thank you, and to your team. And then also Rick Greenwald and John Lurie. They are co-directors for the Center for the Translation of Rehabilitation Engineering Advances TREAT at Dartmouth University. So Rick and John, we really appreciate your teaming up with us. And then last but not least, I want to thank the Agency for Healthcare Research and Quality for having the wisdom to fund this conference, and for the NCMRR for their support that allows us to do this conference. I think that covers most of my thank yous. And so now I have the pleasure of introducing to you a close personal friend of mine who also happens to be my boss, Bob Meenan. Bob is the Dean of the Boston University School of Public Health. He also has the distinction of being the longest serving dean at Boston University, which the president has told him on several occasions, which I've always thought was quite interesting. Bob and I have known each other for a very long time. In fact, Bob was the first person in Boston that I met when I came to Boston in the late 1970s. He's a rheumatologist by training, and he's a health services and clinical epidemiologist as well. He was in the forefront of doing health outcomes research in rheumatology before he got the academic administrative bug, and for over 20 years now has been the dean at the School of Public Health and has led the transformation of a small local School of Public Health into one of the top-ranked schools in the nation. So Bob, thank you for being here.
Thank you, Alan. Well, it's a pleasure to greet you here today. I think you can imagine, having been dean for a while, that I've done this on a number of occasions, and I know how these dean welcome talks work. So you put on a suit, and you go welcome people to a city and an institution that you just arrived at 3 years ago. And I decided I would do it a little bit differently today. So partly dictated by the weather, I thought, TGIF, I won't put the suit on. And as Alan has told you, I can certainly welcome you to the city and to the university based on a lot of time here. I'm actually a Boston native, and I've been at BU now on the faculty for 35 years, as Alan said, first in rheumatology and now in public health. So it really a sincere welcome to a great city and a wonderful and increasingly effective institution. Dean Talks also involve welcoming you to a conference on a topic that the dean or president really either knows nothing about or doesn't particularly care about. But it's part of the ceremonial shtick. As Alan outlined for you, I actually know something about this field and care about it quite a bit. My background, as Alan said, I was a rheumatologist. I did outcomes research, health services research in rheumatology for many years. And I'm fascinated by this, the evolution of disability and the conjunction of disability and outcomes research. And I see it from a couple of perspectives that, informed by my background and maybe the passage of time. I see a couple of major transitions that have been going on, and one is the transition or enlargement of disability focus from a more classic clinical individual care activity to one that really is now population-wide and is relevant to public health. And Alan and I have had conversations about this, about how disability is increasingly a public health level concern. The epidemiology of it, the interventions, and so forth. And we've certainly been talking about how a place like Boston University School of Public Health and BU in general, with all its other resources like Sargent College and so forth, can actually start to span that much broader perspective around disability. Essentially, disability is a population and public health problem. Alan, being a smart guy, recognizes he doesn't have the opportunity anywhere else where the dean of the School of Public Health is a rheumatologist, and the associate dean for planning and resource development is a rheumatologist. So it's a nice conjunction with his interests. The second thing that I see, particularly from a public health perspective, is the growing applicability of disability to global health, to international settings. Quite frankly, for decades, the real issue in developing countries has been childhood mortality and then infectious diseases, and particularly the intersection of those two. And our global health group has focused on that for many years, first diarrheal diseases in India and then AIDS in Africa. But increasingly, Alan and others have been working with people in global health to talk about disability as a growing international health concern. As the demographic transition occurs and the wealth transition occurs, there will be millions of people living in developing and middle-income countries where they have significant disability problems. And any of you who have looked at that recognize that being disabled is a challenge for people in America. It is remarkably more challenging when you're in a developing, resource-poor country. So I think both the clinical to population transition and the domestic to global transitions are remarkably interesting aspects of disability. And the second area that I've been interested in for many years, and clearly is very relevant to this conference, is the whole issue of outcomes research. And I see areas there where the growing recognition of the importance of outcomes research, particularly in a resource-constrained environment. We should be spending our money on things that really work. We should, for a whole variety of reasons, but financial is one of them. And also the recognition that when you're dealing with outcomes research in an area like disability, it has very, very direct implications for things like capacity, human resources capacity, trainees, and methodological capacities as well. And I know that's one of the real foci of this meeting. So I applaud Alan and his colleagues at the other centers for pulling this conference together, and as he mentioned already, to ARC and others that have funded this. I think it really is a very timely, very relevant conference if you look at all those intersections of what's going on in disability, what's going on in outcomes and clinical effectiveness research. So I want to close by applauding you all for focusing on this important area, for coming to this conference to learn about it. I wish you luck in making progress in this field. And I'll close. Alan started with thanks. I'll close with thanks for Alan, to Alan, for sort of helping me work through some of these issues over time, being a great friend and colleague. As he mentioned, I was the first person he met when he came to Boston. What he didn't say, he actually took it fairly easy on me. What he didn't say, he was interviewing for a job and I didn't hire him. We all make mistakes. I learned from it and managed to stay connected with him for many years. Alan was dean at Sargent College here at BU, and I actually was a member of his dean's advisory board back at that time. And then I don't know, about 5 years ago, Alan realized there was a great opportunity and moved back to the School of Public Health to set up his center there, and it's been a wonderful reconnection, I think, for Alan and certainly for me. And I guess I will just be honest and close by saying that he's a better golfer than I am. So, Alan, thank you.
And he hasn't seen me with my new hip yet, so it remains to be seen. Well, thanks, Bob, and thanks for being here, and thanks for letting everyone know that you didn't hire me the first time around. Really appreciate that. I'm going to talk a little bit about comparative effectiveness research just for a few minutes to lay a foundation for the conference today. But I also want to acknowledge the other partner institutions at our R24 infrastructure network. This is a collaboration with several institutions at Boston, and Roger Fielding is here from Tufts University, who heads up one of our cores, and then Spalding Rehabilitation Hospital, and Ross Safant is a co-director of our R24, and so I want to thank them. And I also want to acknowledge Wendy Coster from Sargent College, who is heading up one of our cores as well. So, there's a wide range of experience and talent in the room today, so we thought it would be useful just to do a quick review of comparative effectiveness research. And so I went to the IOM, which released a report in 2008 on this topic, and they put together, I thought, a very straightforward definition. Comparative effectiveness research, or CER, is the generation and the synthesis of evidence that compares both the benefits and the harms of alternative methods. And these are alternative methods not only for treatment, but also prevention and diagnosis, as well as monitoring various health conditions, or to improve the delivery of care. So it's a very broad range of research if you think about that definition and take it seriously. What the IOM argued in their report is that the whole aim of comparative effectiveness research was to assist consumers and clinicians and purchasers, as well as policymakers, to make more informed decisions, as Bob was just noting, that would ultimately improve the health care at the individual and the population level. So if you take that definition seriously and you think about what typically is done and funded by the NIH, it really pushes the envelope in what is traditionally supported by the National Institutes of Health, our major funder. And it really pushes us to think much more broadly about the research that needs to be done to improve the health of our population. And there are also several elements in the definition that I think are important to remember. It's not only the generation of evidence, it's also the synthesis and the dissemination of that evidence. It's obviously the direct comparison of different interventions, and It requires that we look at the potential harm as well as the potential benefit. All too frequently in our work, we focus on benefit and we ignore the harm part. It also includes the implicit and sometimes explicit acknowledgement that we should be studying patients who are typical of clinical care, and this raises design issues that our panel will, I'm sure, get into later this morning, as well as the identification of clinical characteristics that will predict which interventions would be most successful, not only for individual patients, but also for subpopulations of patients. Now, I have to admit, I do have a concern as I read the literature on comparative effectiveness research. The focus tends to be on specific clinical conditions. As someone who is very interested and has spent his career focusing on the disability, I do get concerned that the emphasis is too much on clinical conditions and not enough on the consequences of clinical conditions and people with multiple clinical conditions and the challenges that doing research with individuals with these types of situations has. Many times these people are excluded from the kinds of research that we're talking about here. So I think it really creates some wonderful opportunities for those of us who are interested in disability-related comparative effectiveness research, but I also think it raises challenges for the funders of this kind of research and for the review panels. If we can't convince the review panels to really understand the need to do research with individuals with disability and multiple chronic conditions, no matter how good our proposals are, we're not going to get them funded. So it's really a challenge. So to achieve the goals of CER, from my perspective, and this is also Tonetti and Studensky, who are both prominent geriatricians in the field, they also shared this concern, and they wrote an article in the New England Journal just last year, and they said, CER must address the population that consumes the most health care. And as geriatricians, their focus was on patients, particularly older patients, with multiple chronic conditions, which account for over 80% of Medicare costs. And they're overrepresented in Medicaid and private insurance plans, but underrepresented in much of the research that is currently being done. So they argued, and as someone who's very interested in measuring outcomes of care being provided, I tend to agree with them. A fundamental question is how to define benefit and harm when multiple conditions exist, and we will be talking about that later today as well. And they argued we must move toward a focus on cross-disease or more universal outcomes in research. And they argued the consequences that matter most to patients are where we should be focusing, such as symptom burden, function, and health-related quality of life. And again, if you look at those outcomes and the importance of those outcomes to individuals with disability and the challenges in getting funding from federal agencies who fund this kind of research, particularly the NIH, we have a long ways to go. Other agencies like NIDR are much more comfortable in funding this kind of work, and I think we need to help the NIH to move forward in this area in the coming years. The federal government is into comparative effectiveness research in a big way, and I, for one, applaud this. I think it's very forward-thinking, it's very innovative. In the American Recovery and Reinvestment Act of 2009, there was over $1 billion put forth to support comparative effectiveness research. They created a council, a federal council on comparative effectiveness research, and they have been publishing work. And if you have the chance, go look at what they're writing. It's really interesting to see what they're putting out there with respect to comparative effectiveness research. And the IOM has gotten into this area as well. Then the Patient Protection and Affordable Care Act of 2010, they created the Patient-Centered Outcomes Research Institute, or PCORI. We have a representative of PCORI with us today who will be talking this afternoon, as an independent, not-for-profit entity dedicated to the support of comparative effectiveness research, in addition to the other agencies like AHRQ, which also are here today, the NIH, NIDR, and other federal groups who already are interested in funding comparative research. So I think this is a time of tremendous opportunity for those of us who are interested in disability-related comparative effectiveness research. And there are resources being provided by the federal government to support that kind of work. I, for one, think it's unprecedented, certainly across my career, in the kind of money that is now available to do this kind of research. This federal agency argued that a national CER program, the Federal Council, said it must provide better evidence, so that's obvious and pretty straightforward, but also must improve the uptake of new knowledge and its translation into better decision-making, better care. This, again, is quite innovative if you take it seriously. We've been much better at developing new evidence and new knowledge and much less focused on the methods, techniques, and the science behind diffusing those innovations into practice. Practice lags behind new knowledge considerably. And so to explicitly include that as part of CER, I think, is really important. And to empower consumers and healthcare providers in a dialogue about their care decisions. Among the recommendations that the IOM said is that we must make research into methods of CER a priority. Again, I think this is really important. We'll be talking about it at the conference today, and they're explicitly acknowledging that we need to fund research on better method development. The CER program needs to help develop large-scale clinical and administrative data networks to facilitate observational CER research. I'm sure Ken Ottenbacher and his colleagues were very pleased to see that come out of the IOM report, as we all are. I mean, this is extremely important infrastructure that needs to be put into place in order to ask important comparative effectiveness research questions. Investing in the development of a research workforce with the skills to conduct CER. Again, this is critically important. We've seen that over the past 30 years as the NIH and other agencies such as NIDR, the VA, have invested resources into developing a cadre of researchers interested in doing this kind of research. This is explicitly being acknowledged by the IOM as an important priority that needs to go forward. And in addition, the IOM were so bold, and I would have loved to have been on that panel. They identified the top 100 high priority CER topics, and then they ranked them into quartiles. I can't imagine getting a panel to come to consensus around that kind of task, having been on IOM panels in the past. So my hat goes out to them. They were able to pull that off. The Federal Coordinating Council put together a framework that really encapsulates all that I've just talked about. They not only talked about priority populations, priority conditions, and types of interventions, but they broke it down in terms of comparative effectiveness research itself, the human and the scientific capital for CER and the importance of that, in addition to the research itself, the data infrastructure. No one likes to fund infrastructure. It's incredibly important, and they acknowledge this as an important arm of CER, and then the translation and adoption of CER. And we're talking about T3 and T4 translation, not the kind of stuff that most of the CTSAs do. They talk about translation, but it's all T1, T2. They're not serious about T3, T4 translational research. And what this group is saying is that real translation into practice and into communities is what needs to be done for comparative effectiveness research. So many people have questioned whether, what's new about comparative effectiveness research. From my view, if we really take it seriously, it seems to me what the federal government and these organizations they have set up is saying is that we need to take seriously and invest into what needs to be done in order to move our research enterprise into asking the kinds of questions that will specifically address the quality of care that we provide, and then develop the infrastructure that we can really do that, the capital so we have the people to do that research, and then develop better techniques, better theory, better methods of implementing those findings into practice and transforming the way in which we provide care to individuals with disability. So I, for one, think this is transformational. At least it has the potential to be transformational if we take the opportunity, if we grab it, and which is why we were particularly interested in bringing you all together to do this conference. I just wanted to, near the end here, show this is what the IOM group did. The primary and secondary CER priority areas, they really did begin to very specifically outline them, and they focused on 100. I just want to focus on this one here, functional limitations and disabilities. If you look at primary and secondary, it was near the top, which I was really comforted to see. Not in terms of primary, so that's troubling, but certainly in terms of the combination, it's very near the top in terms of the 100 conditions. And then I mentioned that they did the quartile thing, and these are some of the ones that made it to the top quartile. So prevention of falls, comprehensive care coordination programs, both for children and adults with chronic diseases, prospective registries to compare treatments for low back pain. That one's for you, Tony. And then alternative strategies for detection and management of dementia. I mean, these are really important areas that made the top 25. And then, however, you know, someone had to be in the lowest quartile, right? Some of these are troubling. Sorry, Bob, different treatment strategies for osteoarthritis. It was in the lower, it was at least in the 100, but it was in the lower quartile. But these are some of the others. These are incredibly important areas, but they didn't make the top quartile ranks. Okay, I'm done. Tried to set a foundation for what the rest of the day will be focused on. We've tried very hard to not only bring in speakers who really had something to share with you, but to structure the day so that we had the opportunity for dialogue. Last night, we had the opportunity for very informal dialogue in a very relaxed, cool, wonderful forum. I mean, for those of you who went there, it was sweltering. I mean, it was wonderful, but it was sweltering. So we're going to next go into a panel, and there are many issues around designing comparative effectiveness research, and our panelists will lay out some of those issues, and then we'll have the opportunity for questions and discussions about that. And then we're having plenary sessions after that focused on some key topics in comparative effectiveness research: diagnosis and classification, defining treatment interventions, and outcome measurement. If we can't tackle these, we can't do comparative effectiveness research. They're absolutely critical. And then lunch. We'll let you eat. We're going to be moving the party to the Hillel House just down the road for lunch. Then we'll have workshops this afternoon, which Mary will talk more about later. And then at the end of the day, we have several representatives from federal and not-for-profit agencies who are interested in funding comparative effectiveness research, who will be available to present some of their views on funding and then dialogue with you, which we hope will be of great interest and value to all of us. So thank you. We're delighted that you're here today, and we look forward to an exciting rest of the day. Thanks. I would ask the panelists to come up to the, whatever you call that, and then I'll introduce our first panelist. Our first speaker is Dr. Nancy Latham. Nancy works for me. She's a research assistant professor at the Health and Disability Research Institute. She's co-director of the training and the didactic core at our Boston Rehabilitation Outcome Measurement Center. Nancy is, over the past 4 years, has been directing a comparative effectiveness trial of rehabilitation and strength training following hip fracture. Nancy, thank you for being with us.
Thank you. Well, it's great to be here and to be able to kick off this panel and talking about the pros and cons of efficacy randomized controlled trials. Any research design needs to be a match for the research question. And comparative effectiveness RCTs, the main aim of these is usually to compare the potential benefits and also the potential adverse effects of one intervention to another. An efficacy RCT is a specific type of RCT that is evaluating interventions under very carefully controlled circumstances. So the people enrolled in these studies tend to be highly selected. The interventions are delivered in a way that is probably going to ensure the ideal sort of outcome will occur. And this is in contrast to the pragmatic RCTs that John's going to be talking about next. If conducted properly, these types of trials provide a very high level of internal validity. So this means that these studies provide really the highest odds that we have of finding out if an intervention is truly superior to another intervention. What randomization allows us to achieve is an unbiased distribution of potential confounders. So confounders are those variables that are associated both with the treatment outcome and with the treatment intervention. And this can lead to confusion about what really is that association between the intervention and the outcome. What randomization does that really no other design can achieve is it distributes both the known confounders and those unknown ones, the ones we just haven't thought of, or the ones that are just so difficult to capture and to measure. Now, a word of caution, randomization is not a miracle. It alone is no guarantee of a valid result. A poorly designed RCT, for example, a trial that lacks other elements such as blinding, intention to treat analysis, or one that is just so small that it's prone to random error, is not going to yield strong evidence and will lack internal validity. But randomization is the best approach that we have for dealing with this issue of confounding. And the reason I come back to this is that confounding is such an issue when we're trying to assess the relative efficacy of interventions. And this is because there often is a strong association between interventions and between the underlying clinical problems or functional problems that people have. We call this confounding by indication. And just to give one kind of basic example, it would be if somebody, say, had chronic headaches. An example of this would be someone with long-term chronic headaches is probably going to take more ibuprofen or other sorts of analgesics. If we were just observing those people, we might think that those medications were actually causing of the problem with the headaches. But in fact, it's the fact that they've got more severe underlying pain is the real problem there. That's what is confounding that relationship. It's another variable. But if we were just observing that, we might misinterpret that relationship because of the confounding. I wanted to just bring up what's probably one of the best known examples where observational data was inconsistent with randomized data, and that is looking at hormone replacement therapy to prevent cardiac events, MIs, in women. I think a lot of us can remember going back a decade or a few decades ago now that there were a large number of very well-conducted observational studies that found significant cardiac benefits. We're talking about like a 40 to 50% risk reduction in cardiac events for women who took hormone replacement therapy. And this was being widely promoted, not just by the pharma industry, but across the medical field for women to take this. Unfortunately, or perhaps, I guess fortunately, when the well-conducted efficacy RCTs were conducted, such as the Women's Health Initiative and other studies, they found absolutely no evidence of cardiac benefit. And in fact, they found evidence of strongly increased harm. Women were at much greater risk of breast cancer. Now, in hindsight, the assumption is that women who took HRT were healthier, had healthier behaviors in ways that reduced their cardiac risk, even though these studies tried very hard to adjust for these risk factors in their multivariate analysis. For example, they took things like smoking and other behaviors into account, but there were clearly unknown, unmeasured confounders that they did not pick up. This caused harm, this sort of mistake. It is now thought that the significant reduction in breast cancer cases that has occurred from 2002 until about 2005 is attributable to the decreased number of women taking HRT as a result of these trials. If we take it from that example back to thinking about disability and thinking about the potential for confounding when we're observing the relationships between interventions and outcomes, I can think as a physical therapist, for example, about when I'm designing an intervention program for somebody with spinal cord injury. I've got a range of interventions that I can choose for somebody that vary enormously in their challenge, their difficulty, their novelty. And the reason that I select these, there are a large number of reasons. I've listed some of them here. And these are potentially, these reasons that I select things are things that could all confound that association, where we might think that that new gizmo that we have is really what is causing somebody to have a better functional outcome, but it's in fact that it's the really motivated, determined people who we're selecting to give that to. There's some problems with this list that I've got here. The first is that it's a long list and that it's difficult to measure some of these things and time-consuming to measure these in this study. And the second is that there's no way I've got all of the confounders on this list. This is not an exhaustive list, and there definitely will be things that will be missed. And those could be important variables that if we were just observing, we would need to know to really understand if that intervention is making a difference to the outcome. I wanted to give an example of what I think is one of the strongest comparative effectiveness studies in the rehabilitation disability area, and that is looking at the issue of arthroscopy versus physical and medical therapy for knee OA. In 2006, there were about 1 million knee arthroscopy surgeries done in the US at a cost of about $5 billion. Now, not all of these were for OA, but a large proportion of them were. The efficacy of this was unclear. Observational studies had suggested benefit, but there was also one RCT that had been done that showed no benefit. However, there were legitimate methodological limitations, so this study was basically disregarded, as you can see by the fact that 1 million were done. Kirkley et al. Conducted an RCT exploring this issue. They included people with moderate to severe knee OA, and the two groups were arthroscopic surgery plus optimal PT and medical therapy versus optimal PT and medical therapy alone. The primary endpoint was the well-validated WOMAC score at 24 months out. 188 people were randomized, and the study was successful in that they had a relatively low number of dropouts and few crossovers in the treatment groups. However, when we look at the outcomes here, if we're looking at this if we're looking at the graph, you can see, I'm sorry.
Nancy, you could use the other pointer, Mike, if that's what you're looking for.
Okay, thank you. I'm just going to get back to the point. The graph is showing in red, which I'm just not even going to point at it. In red is the arthroscopic surgery group, in blue is the control group, and along you can see that it's graphing the WOMAC score versus the months since randomization. And the important point I was just trying to make visually is that at all of the follow-up endpoints along the different months from 3 months to 24 months, there was absolutely no evidence of benefit. So this is, again, probably an example where the people getting this intervention were who knows what, more motivated, more determined, had more money, who knows what. But there was something different about them that the observational studies hadn't picked up, that the randomization is now showing, that this intervention, which is expensive, which is painful, which is invasive and potentially risky, really does not improve these outcomes at all. So randomization and efficacy RCTs are important, but I do not want to give the impression that I think that efficacy RCTs are the answer to every research question. Clearly, there are many research questions for which this is not the most appropriate design. For a few examples, treatments that require a very long period of intervention in order to see effects, or for determining very rare but potentially serious adverse effects. We also face, I think particularly in our field sometimes, ethical problems, in that we've got a lot of interventions that have been widely adopted in practice without any evidence of efficacy. However, it is probably an ethical issue at this point when they're so widely used to randomize people to not receive those interventions. This presents a real challenge. There also is no need to do these interventions if the evidence of efficacy is so overwhelming. And I just like this BMJ article that I think tweak people like me who are maybe get overly earnest about RCTs, that a study to look at parachute use to prevent death and trauma, not necessary in this example. When we're thinking specifically about efficacy RCTs, in contrast to John's pragmatic trials, again, there are limitations of these in that the subjects are so highly selected, the treatment's so well controlled, that if we're trying to generalize this to the real patients in the real world, these very constrained studies have limitations in that generalizability. But I think the biggest barrier that people bring up for RCTs is the cost of them. The cost, the time, and the fact that they're fairly inefficient to do because we can usually only look at a few interventions at a time. But just before that leads us to the conclusion that we should not do efficacy RCTs, that other designs are necessary, I would just like to raise with this group the question of, is there some way that we can think of doing RCTs more cost effectively? It seems to me that the model for doing RCTs has barely evolved over decades. I think that most people in this room could attest to the fact that there are extremely high costs with each individual RCT in setting them up, in hiring and training the staff, in establishing the recruitment sites, in setting up the data management systems. A recent IRM report issued just a few months ago, actually, looked at this issue at clinical trials infrastructure and made a number of compelling recommendations that funders, industry, consumer groups, and other groups could do to potentially reduce, not to make them minimal costs, but reduce some of the costs of RCTs and increase the efficiency of them. And I think this is really worth thought and consideration. These studies are hard to do. Especially for disability-related CERs, we face challenges in that for these types of studies, we need to identify the right people and get them to agree to be randomized to one treatment group or another. They're needing to give up their autonomy for making that decision about their intervention if they adhere to it. And this is really challenging, especially if someone with a disability is either attracted to a new intervention or even more if they are used to a device, to a service, to a practice that they've been using for a long time. To ask them to be randomized to potentially to something different, that's a hard sell to get people into these studies. And it brings up a second but related problem, and that's when we're conducting comparative effectiveness research, there's a real problem of the potential of people to cross over from the assigned treatment group to the other treatment group. The SPORT trial, which was looking at surgery versus non-operative treatment for lumbar disc herniation, is a great example of this. This was an extremely well-designed and conducted efficacy RCT, but at 2-year follow-up, 40% of people in the surgery group did not actually have surgery, and 45% of people in the non-operative group had surgery. So it made it very difficult to determine the superiority of one treatment compared to another, and this is a really common problem if people tend to be naturally biased to wanting one treatment more than another. It's a real issue, practical issue that we face in these studies. So just to summarize, I feel that we're at a really exciting point in time in disability and rehabilitation research. We have so much new technology that is emerging that I believe is going to increase treatment options and change the way we deliver care to people. But I also believe it's imperative that we evaluate the risks and the benefits of these approaches before they get widely adopted. Efficacy RCTs are clearly not ideal for every research question, but randomization is the only approach we truly have to balance the known and the unknown confounders, and we know that those confounders can influence the association that we see between the intervention and between the outcomes, and confuse the conclusions that we draw if we're just looking at observational data. Consumers with disability and clinicians need reliable evidence to guide complex treatment choices. The interventions that people with disability often get involved with involve a lot of their time and personal commitment. And if we're asking people to do these interventions that have no benefit, to me, that is causing harm. Before we reject RCTs, we have to accept that RCTs are expensive, and that is a limitation. But I think that an issue that we as a research group and people interested in disability research need to consider is what could potentially be done to evolve RCT design and the overall research environment that we're all operating in to perhaps make RCTs a feasible option for more disability-related research questions. Thank you.
Is this mic on? We have a couple of minutes for questions, and we're going to have time at the end for general questions to the panelists. If you have a question you want to ask, please use the mic. There are a couple people circulating who have a microphone so that people webcasting can hear your question.
Nancy, I have a question. It's Kathy Sullivan from the University of Southern California. You used two words, and I wonder if you could distinguish for us the difference between disability research and rehabilitation research.
Oh, Kathy, I think that's a really, I think that's a really important question. I think that it's one that you're right. I did overlap those issues. I think that, to me, disability research is much broader than just rehabilitation research. To me, disability research is encompassing the huge proportion of us who have some sort of condition that limits their functioning. And so it could be any interventions, including things in the environment or things that relate to that. Whereas to me, rehabilitation is a more narrowly focused subset of that, looking at interventions delivered more traditionally medically or delivered by the traditional medical rehabilitation professions to address shorter-term problems with that. But there is such because rehabilitation is a subcategory of that, I did use those terms together. Right.
I'm going to ask people to hold further discussion or questions until the end of the panel. Thank you, Nancy. Our next speaker is Dr. John Lurie. John is Associate Professor of Medicine and Orthopedic Surgery at Dartmouth School of Medicine and the Dartmouth Institute for Health Policy and Clinical Practice at Dartmouth College. He's also co-director of the Center for the Translation of Rehabilitation Engineering Advances. John, thank you for being with us.
Thanks, Alan. So in talking about pragmatic clinical trials and sort of pros and cons, most of everything that's important to say about that Nancy already said. So pragmatic clinical trials fundamentally are just randomized clinical trials. And the difference has to do with the question that you're interested in and the focus that you're interested in, and that drives all these decisions about the specific design. And so I'm going to go through mostly examples about why this matters and the spectrum between efficacy and effectiveness or explanatory and pragmatic clinical trials. Alan also asked me to keep these remarks short so we have more time for discussion. So don't get too attached to the slides, because I'm not too attached to the slides. I'm going to sort of skip through some stuff. Anything that's important we'll focus on. So this is the most important slide. Right? You got to be careful if you don't know where you're going, otherwise you might not get there. The thing that drives study design and the pros and cons is always about the question. What is it that you want to know? And the other way to say that, in more grammatically correct terminology, was from Claude Lévi-Strauss: the scientific mind does not so much provide the right answers as it asks the right questions. So this clinical trial design spectrum really is a balancing act. It's a trade-off between these two forms of validity, internal and external validity. Right? So this is my layman's definition of these two terms. Internal validity says the answer that you think you got is the right answer in the population you studied. So the conclusion you draw is the right one for the people you looked at if you had some sort of truth with a capital T that you could test it against. External validity means that the answer that you got in the people that you studied is the same answer that would be obtained if you'd studied the rest of everybody. Okay? And these trial design issues are balancing those two. And so you have these trade-offs, right, between internal and external validity. Other ways of saying that is efficacy. Can the thing work under ideal circumstances? Or effectiveness. Will it work out in the quote-unquote real world? Explanatory or pragmatic clinical trials is sort of that same spectrum. And for me, explanatory clinical trials are often about hypothesis testing. If I do this, will I get this result? Pragmatic clinical trials are about decision making. What's going to end up with the best results for a patient or a subject? Right? There's two reasons for this sort of trade-off and more of an interest in pragmatic clinical trials. One is sort of coming to a realistic assessment of how internally valid our best attempts at efficacy trials are. Right? So what's a perfectly valid study? Internally valid study. What would you want to be able to say, this intervention caused that result? Well, you'd want homogeneous groups. You'd want identical environments. You'd want identical interventions on everything except the thing that you randomized. Right? That intervention would be delivered the same way to everybody. The follow-up would be 100%. The outcomes would be reliable and objective, and the data collection would be completely uniform. Right? That's the ideal internally valid study. You can do that with some inbred strains of mice. You can approximate it in short-term physiology studies or critically ill patients, right? If you want to do long-term studies in free-range humans, forget about it. Right? Their environments are not the same, their genetics are not the same, the interventions are not the same. Nothing about them is the same. They're people. And for some odd reason, in particular in the United States, they do what they want. In Europe, they get to, you ask people to do stuff, they do stuff. In the United States, you ask people to do stuff, they go, eh. Right? So you have this trade-off. I'm going to skip that one. So even our best attempts at internally valid studies are limited. But then you have this other problem of external validity. It's much less well defined. And nothing is generalizable in any real sense. Some things are generalizable to some things and not to others. But what are the key factors? And this has been much less studied than sort of the internal validity side. But sample size, how big? The bigger the trial, the more likely it is to be generalizable because you have more people in it. Selection criteria, how strict. Treatment regimen, how realistic, how implementable, how realistic was the compliance within the trial, the treatment setting, and the study setting, right? And so there's all these dimensions, and this is a tool that was developed by a group of investigators, including Sean Tunis, to assess the degree of pragmatism of a trial. And what's important there, you can't read all the spokes of that, and that doesn't really matter. What is important is that it's a multi-dimensional thing. It's not that here's an efficacy trial and here's a pragmatic trial. It's that different trials are on a spectrum in sort of different aspects of that. How strict are the inclusion criteria? How flexible is the intervention to adjust to the individual versus the same in everybody, right? And those are all those criteria. And this is just a comparison of an extremely pragmatic trial where the intervention is very flexible, the criteria are very broad, right? It covers sort of real practice. This is a very typical explanatory trial. All those characteristics are in towards the center of the explanatory. This one happens to be the NASET trial, the North American Symptomatic Carotid Endarterectomy trial. I raise that because I'm going to show you an example of some data from that as to why this distinction matters. Okay, but it's a very explanatory trial. This is only for the gestalt of those two pictures. This is studying the same intervention. This is a very more pragmatic way to study. This is low-dose aspirin for the prevention of preeclampsia in a very pragmatic implementation and in a much more explanatory implementation. So strict, rigid controls, more like real practice. So why does this matter? Again, you can't read that. You're not supposed to read it. You're only supposed to get a feeling for how many lines of text are on there. Right? These are the exclusion criteria in the carotid endarterectomy trials. Right? Lots of exclusions. Appropriately, because what they wanted to answer was the explanatory question: can carotid endarterectomies reduce the risk of stroke relative to medicine in highly selected ideal candidates? Right? And so this is how they set it up. Now, here's the result of that. So they did an explanatory trial, they got an explanatory answer. But what does that mean for a practitioner? Okay, this is from a trial registry at one of the same institutions that the trial was held at. Right? So this is one of the participating centers. Of the people who got carotid endarterectomies, half of them wouldn't have been allowed in the trial. So what do we know about the efficacy of carotid endarterectomy in that group? Not too much. And this is a really important slide. So this is the outcomes. This is the 30-day mortality rate, right, so the harms after carotid endarterectomy for Medicare. So this is the rate, 30-day mortality rate in the trial for asymptomatic carotid endarterectomy. This is the 30-day mortality rate for the symptomatic carotid endarterectomy trial. This is the mortality rate for people getting carotid endarterectomies at the sites where the trial was done. Okay? And then these are the mortality 30 days after carotid endarterectomy at all the other hospitals in the United States that were doing them. Right? And this is high volume, medium volume, and low volume. So what does that tell us? High volume hospitals have lower mortality than low volume hospitals. The trials that were selected to be in the study had lower mortality than even the high volume best places. And the mortality in the trial was about a third lower than the mortality of the people at the trial sites that were actually getting carotid endarterectomy. So there's nothing wrong with the data from this study. It tells you what it tells you. It tells you what the potential efficacy of carotid endarterectomy is. That's useful scientific data. What it's not useful for is helping your grandmother decide whether she should get a carotid endarterectomy, because she is most likely, on a probability basis, to get her carotid endarterectomy here, because that's where most of them are done. she's not going to get this one. She's going to get that one. And if she uses this data to make that decision, she's going to make a bad decision. Right? So that's this distinction between hypothesis testing and decision making in trial design. And I'm going to skip that one, I'm going to skip that one, I'm going to skip that one. So these are the characteristics of pragmatic RCTs. Select clinically relevant interventions, include a diverse population, recruit participants from a variety of practice settings, and collect data on a broad range of health outcomes. And I thought I'd fix this slide. I didn't fix this slide, so I'll fix it in words. Right? Comparative effectiveness, effective comparative effectiveness research is going to require getting, and this is from another talk, different audience, getting clinicians to think more like researchers and getting researchers to think more like clinicians. Right? So this, I'm going to skip. This is an example of a pragmatic trial. The only thing of use for this trial is going to be two things. So don't try to read this. This is the aims of the trial. What I want to point out is this is a fall prevention trial, 2 different interventions in physical therapy to prevent falls in the frail elderly. The first aim is to assess the impact of these 2 interventions on whether or not somebody falls. Okay? This secondary aim is to look at the heterogeneity of that outcome in this population over time, right? So we do the intervention, we follow people for falls, right? At some point, we have to sort of do our analysis and say this group fell more or less than that group. But then we have the question, does that change over time? Of course it changes over time. But we won't know how until we study it. So most of the time in trials, you just have sort of this average effect. You compare the 2, you have a p-value, and you're done. Well, that's not the way the world works. So one group may fall less, but how long does that effect last for so that we know how to organize our treatments? And different groups of people, when you have broad criteria, they're probably going to respond differently. And how can you look at whether or not there are predictors of who's going to do better or worse? And then the last thing I'm going to say, I want you to remember that NASIT slide. This is the inclusion-exclusion criteria for this trial. And this is the list of outcome measures for this trial. So very few exclusion criteria, lots of outcomes, because we want to know what works in real patients, and we want to know multiple dimensions of how that affects them. Thank you.
Thank you, John. We have time for some questions or comments for the speaker.
So yeah, thank you. One question, I guess, are there things in more rigorous randomized control trials that you can do to make them more like effectiveness trials? I mean, I worry about the healthy cohort effect, and
Right.
how you design your trial to make it more appropriate.
Yeah. That's a great question. It makes me get up here. I want to go back to a slide and say something that I had tried to remember to say, and I forgot to say. There we go. So what's as important about this slide is then what is on here is what is not on here, right? So this is the spectrum of efficacy in pragmatic trials. What is not on this spectrum? More rigorous, less rigorous. Not on this spectrum. Easier, harder. Not on this spectrum. Pragmatic trials are not less rigorous, not easier to do. But no, I'm not disagreeing with you. It's a really important point, because people often think of pragmatic trials as, well, it's like an efficacy trial, except you can't really control things as much as you want. But in fact, the point of a real pragmatic trial is that you don't want to control things that aren't controlled in practice. You want them to be practiced, but you want to control everything else as tightly as you can. You want to be just as rigorous in asking the question does this intervention as delivered in practice produce different results as you would be rigorous about saying under ideal circumstances, does this intervention cause different results? So it's tightly controlled. The issue of sort of the healthy cohort and those sorts of things are exactly the same or are similar in pragmatic trials as they are in efficacy trials. That is, it's still a randomized trial. You're still not getting everybody in. There's still a place for observational research because some people aren't going to be willing to be randomized. Some people are not going to be competent to give consent to be randomized. And the outcomes in that set of people are important as well. When the intervention is more flexible and can be adjusted to the individual, sometimes there's less of a barrier for people to participate than if they know that they have to get this thing every week and whatever. So it's a little bit sometimes closer to an observational study, but it's not. That's the key. And I think, unfortunately, some things that sort of get treated as pragmatic trials are just not particularly rigorously done attempts at efficacy trials, and that's sort of the really important distinction. Good pragmatic trials are just as rigorous, just as hard, just as tightly controlled on the research side as an efficacy trial. What's not tightly controlled is the intervention, because you want it to be a real-world intervention.
I guess this question's for John. Do you have any suggestions for dealing with journals that are reluctant to publish studies that show no difference between treatments, especially in a pragmatic type trial?
Yeah. So that's it's a fundamental problem. Publication bias is a huge problem. I think the world is, comparative, one of the sort of positive unintended consequences of comparative effectiveness is it's easier, I think, for reviewers and journal editors to understand why a comparative effectiveness trial that shows that two things aren't different from each other is not a negative study, and are more willing to see the benefit of publishing that. And I think a lot of the work around with meta-analyses and the work around the problems of publication bias have led people to understand that negative results in a well-designed question and a well-designed study are as informative as positive results. That is one downside to the pragmatic approach, is if you sort of have a complex intervention that has multiple parts, and it's being applied sort of not exactly the same everywhere, and it doesn't work, I guess the key to helping them understand there is to make sure that we write our manuscripts in the way that makes it clear what the question was, right? So if you have, often people look and say, well, it wasn't delivered the same way everywhere. And so if it didn't work, it might be because this person didn't implement it right. And you can sort of help people understand that better if you make it very clear that what the question was. The question was, does this intervention as applied and individualized to patients or adjusted, make a difference or not? And they're most people are pre-programmed to think about an RCT in the other model that works well for pharmaceuticals, and that's who did all the RCTs for a long time. And so everybody thinks that what works for pharmaceuticals is the right way to do things, and we're slowly getting out of that. They're coming. As more are done, people sort of get more familiar with the issues, and conferences like this might help sort of get the word out. But negative studies are a very difficult problem.
Thank you, John. So if you miss it the first time around, you get a chance to see it the second time. Our next speaker is Dr. Gerben de Jong. Gerben is the director of the Center for Innovation and Post-Acute Research at MedStar National Rehabilitation Network in Washington, D.C. He's also professor in the Department of Rehabilitation Medicine at the George Washington School of Medicine. Gerben.
Thank you, Alan, and good morning to all of you. I like to start off with greetings from my home base at the MedStar National Rehabilitation Hospital in Washington, D.C., and also the Georgetown School of Medicine's Department of Rehabilitation Medicine. With that, what I like to do is also like to acknowledge a couple other things, too. First of all, I want to say thanks to Alan and Nancy and others for inviting me here. It's been a long-term relationship that we've had with BU over the years, and I've always found it to be intellectually stimulating and very productive. I also have to acknowledge another colleague that I've worked with very closely, and that's Dr. Susan Horn, who's out in Salt Lake City. She and I have been working on a number of cohort studies for the last 12 years or so, and I've been doing cohort studies for a long time, even prior to that, but I have to make that acknowledgement as well. With that said, let me proceed with this statement here. I guess we're moving down the spectrum here from clinical trials to observational studies, and this observation that all observational cohort studies are crap. And this is something that David Newman, an emergency physician at Mount Sinai, said. I heard him at a conference as a dinner speech. And I thought, well, okay, let's see where he's going to go with this. And it was very interesting. He's a very entertaining speaker. And please do watch his YouTube presentation, which I've listed over here. Because he does speak to, he mentions the HRT trial as well, which resulted in some misleading results. And later on with a randomized trial, we found out that the observational studies did not take into account all the confounders that were there. Another favorite line that I hear all the time about observational cohort studies is that they're nothing but fishing expeditions. That one I hear all the time as well, and they're very, very easily dismissed. And I must have to say that when we talk about cohort studies, there's a wide spectrum of them. I'm not going to try to explain all the different varieties. You see some of them listed here. You know, they could be population-based epidemiologic studies on specific cohorts. We could also be looking at specific treatment interventions and making comparisons. But the only thing you need to remember is that according to Newman, all such studies are crap. All right. With that said, I think at the heart of the critique of observational studies is that they at best examine association and not causation. We've heard it beaten into our heads all our professional lives. Association is not causation. All right. And we talk about association and causation in very dichotomous terms. And I like to suggest that we need to think about it as a continuum, as a spectrum, so to speak. At one end, where we have very clear causation, at the other end, where we have spurious association. And what we want to do is move, basically, from one end of the spectrum to the other. We want to move this way as much as we can. And sometimes what happens is randomized trials is not necessarily practical, and as a result, we just can't get here. But what we need to do is try to control for all the patient covariates and also for all the potential confounders that might be in there. And with multiple studies saying the same thing over and over and over again and controlling for things in different ways, we can move with increasing confidence toward this end of the continuum. We may not get here exactly here, but over time and with more studies and with more control, we do tend to move here. So I just want to get that picture in your head for a moment so that we don't get into an either-or kind of thinking about whether or not it should be a cohort study or whether it should be a randomized trial. All right. As we know, this particular hierarchy of evidence I've seen maybe 13 or 14 different hierarchies over the last, shall we say, couple of decades, ever since David Eddy made these very famous. And I'm not going to try to explain this, but clearly observational studies just don't rise to the top of this particular evidence hierarchy. And these evidence hierarchies are very much institutionalized, whether it's in things like the Cochrane Collaborative or even the Campbell Collaborative, which deals with social and evaluative scientists. It's built into our journal, journal peer review, and certainly I think also into grant reviews that are done by various funding sources. This evidence hierarchy is part of the implicit, if not explicit, evaluation criteria that are used in order to evaluate proposals for research funding and also for papers for publication. All right, and I'm going to skip over this slide since I've addressed it to some extent already. All right, so when are observational cohort studies really appropriate, okay? And, you know, they're appropriate in many different ways, but certainly when we're searching for we're trying to examine theoretically plausible relationships between risk factors and interventions and outcomes, especially at the exploratory stage of an investigation. So very often, I'm going to show pretty soon some exploratory results that we came up with. Had we not found those and we had designed a randomized trial right away, we would have made a huge mistake in the way that the trial was designed. Okay. And also, I think observational studies are also very important, especially when the interventions are very much, shall we say, multifactorial, okay, and where you have a lot of different things going on at the same time, and where it's very difficult to control exactly all the interventions that go on simultaneously. I think we try to compare systems of care, and especially, it's very difficult to design a randomized trial around entire systems of care. And this is a case of where we may want to resort to some kind of observational cohort study. All right, and clearly when the denying of an intervention poses a serious ethical risk in the use of a randomized trial, you probably would also want to use an observational cohort study as well. The other thing I want to point out is that the way one designs a randomized trial, very often it depends where from the population distribution does one sample, all right? And so that the treatment effect here is going to vary somewhat based on what sample that we choose. If this is the entire population distribution, and if you choose randomized samples from very narrower, smaller groups, you're going to probably end up with some misleading results. And one of the nice things about an observational cohort study allows you to broaden, shall we say, the selection criteria a little bit so that you can begin to see how the treatment may affect various subgroups and do that kind of analyses in what I would call subgroup analyses. Well, here's a starting list of all the differences between RCTs and observational cohort studies. I'm certainly not going to go down this list. Just want to just emphasize a number of things here. And the two big things, I think, is controlling for participant differences through randomization, but also in a good observational study, if you have detailed characterization and try to control statistically, you can get a lot of control. You won't get perfect control, or won't get to all the things that Nancy talked about motivation or other kinds of things that may influence the participants' behavior. Nonetheless, I think that what this requires a tremendous investment in trying to get detailed information about the individual, about the patient, about the subject, about the user, all right? And that is that's a very costly and expensive process to get that kind of data, but it's essential to the control process and trying to control that statistically. But even then, you can't control all the differences, and I'm going to share with you some potential confounders that are going to occur, all right? And also confounders are things that you really want to not only minimize with RCTs, but they're not particularly interested in them. You want to exclude them. Whereas when you do an observational cohort study and you come across confounders, you want to struggle with them and you want to really understand what might be behind them. They're interesting. All right. I'm going to skip this as well, except to underscore what was said earlier, is that randomized trials are enormously expensive. I mean, if you take the LEAPS trial, which is probably the single largest randomized, or probably the most expensive trial done in the United States, I think was in the order of $14 million or something like that. You know, how many $14 million studies can we afford to do? I mean, I don't think there's enough money in the entire NIH budget to look at all the combinations and permutations of various interventions that are used, shall we say, in disability and rehabilitation research. I'd like to just share a few thoughts about a study, kind of a monster study that we did several years ago called the JOINT study. And the JOINT study was really trying to look at two different systems of care with respect to rehabilitation for total hips and total knees, and comparing skilled nursing facilities with inpatient rehabilitation facilities. We had 22 facilities in the study, 11 SNFs and 11 IRFs. We had over 2,000 participants, as you see there. It was published in a 5-article series in the archive. Several other articles have come out since then. This is a very large study. We looked at a lot of different outcomes, the primary outcomes being those of functional outcomes, particularly at discharge. We also looked at follow-up. We looked at things like medical complications, discharge destination, post-discharge use of additional health and rehabilitation services, particularly interested in looking at hospital readmissions, self-reported health, resumption of usual activities, and so on and so forth. Put it all together, what we found is that IRFs had marginally better outcomes. And I say marginally, and having said that, there was a very important, what I would consider to be a confounder in all of that, in this finding, and that's really this characterization here. And also will tell us something about the design of randomized trials. If we were to do a randomized trial trying to compare IRF care with SNF care with respect to joint replacement rehabilitation. What we found basically here is length of stay is on this axis, intensity of PT and OT is on this axis. This is hours of therapy per day. And what we found here is that the IRFs are pretty well clustered in a fairly narrow, small box here. All right, so in other words, they provided high intensity care, but for a short duration. The SNFs provided, shall we say, lower intensity care, but for longer duration. We also had an odd facility, which is a hospital-based SNF, which had elements of both. That is to say, it had the short length of stay of an IRF, but the intensity of a SNF, and we treated it differently as a result of that. Now, what was interesting about all of this was to see the variation in practice here. If we're going to compare SNF with IRF care, basically you have to say that a SNF is not a SNF. There is some variation here. Now imagine for a moment you were to design a clinical trial, an RCT, where you chose patients mainly from the facilities in the northwest quadrant of this box here, and you chose patients from the southeast section of this particular group. You would probably see some very significant differences in terms of outcomes because of the variation and because of the intensity factor, all right? But then, on the other hand, if you chose a group here and compared them with a group here, you probably would see almost no difference. My point basically is when you do a randomized trial, you use a limited sample, you probably wouldn't go to 22 different facilities, but you would choose a subset, and which subset of those facilities you would choose could make a material difference in the outcome, mainly because intensity was a driver in the outcome, all right? And one of the confounders that we're dealing with, was it intensity or was it the setting of care? Well, by definition, an IRF offers higher and more intense services because the 3-hour rule says you need 3 hours of therapy. SNF care is lower intensity. Intensity makes a difference. The question that we could not address and sort out adequately was it the setting or was it the intensity? All right? But the truth of the matter is intensity defines a setting, so that's how it all gets shaken out. But you needed to know these practice patterns in order to really design a good randomized trial. And you would need to have this kind of a cohort analysis before you would ever go to some kind of an RCT. All right. Now, the other thing that we also learned, we learned about the patterns of post-discharge use and their association with outcomes. And one of the things that we found, for example, is that these folks went on after their rehabilitation to get home-based therapy and outpatient therapy. And they got as much therapy in the follow-up period as they did in those two settings of care. So what was the treatment effect? Was it because of the settings of care, or was it where they went to later on? All right? And what they got later on was also in part what institution they went to initially for their care. All right, so what we ended up was getting is a much fuller and clearer picture of the entire episode of care, its associated outcomes, and what it might mean for the future of post-acute policy. All right, but I also want to deal with the issue of some other confounders and other things. One of the things I found, and one of the things that's really frustrated me in observational cohort studies, is the fact you see relationships that seem entirely counterintuitive. Sometimes the counterintuitive findings are very interesting and get you to start thinking altogether different way about what might be the cause and effect. But one of the things that's really hard to sort out, for example, right now I'm looking at a pressure ulcer study in spinal cord injury. And what we're finding is that people who got more patient education with respect to skin management and so forth actually also had more skin breakdown. So how could that possibly be? Well, the reason for that basically is that those that got a skin breakdown also came in with a pressure ulcer, were at higher risk. They got educated for the initial pressure ulcer. All right? So the patient education and its association, its negative association with the outcome, is a potential confounder, but it's related to the fact that they were admitted with a pressure ulcer, all right, and acquired additional education. But the problem is you could actually try to control for all of these things, and you would still end up with these unusual associations. All right. And sometimes we also find that the more of a therapy a patient gets, for example, Nancy a moment ago had mentioned about the use of pain relievers and headaches, and you would say, well, the pain relievers were more pain relievers was associated with more headaches. You have the same thing also, for example, what we find in looking at rehabilitation therapy is that the more, shall we say, bed mobility training that a person received, they had worse outcomes. And what's going on here? What's really going on here is that their focus on low-level bed mobility was also a measure of, shall we say, functional status of the patient, all right? And basically what happens, all the functional control, all the other covariates, all the other controls that you had didn't capture all the differences that you found among patients, all right? So these are kind of some of the interesting things that you observe in observational studies, which I find immensely interesting, immensely useful. All right, but I do want to just end up with a little bit of an editorial here, if I may, and that is this. I have some other things to say about observational studies and randomized trials and and some people have done great jobs of trying to compare, shall we say, studies that have focused on randomized trials, compare them to the results of observational studies, and have found a pretty high relationship between the two of them in terms of consistency and findings, despite some of the unusual results that we've had reported this morning. But you know what strikes me as I look at the whole area of outcomes research is that a lot of what we're doing in research is to mitigate what I call the effects of payment systems that we have. And the truth of the matter is payment is not aligned with outcome and with results. We don't necessarily pay for performance. We're moving in that direction. We're moving toward value-based payment. And, you know, the question that I keep asking all the time is this: can we design a payment system that will really encourage providers to figure out what is the best way to do things? Because providers are smart. They're intelligent. They didn't get to medical school by being dumb. You didn't get to PT school by being dumb. All right? And what I find is that clinicians have enormous wisdom when it comes to treatment and trying new things and ideas. And I really believe that if we had payment systems that were better aligned, that we would find more effective ways to try to get to best practice. And we would do so iteratively. We might have to do it through some randomized trials, through cohort studies, or whatever. But, you know, it seems to me that if we want to get the best practice, there's just not enough money in the entire budget of the federal government to do all the things that we want to do. And I would say that part of what we're trying to do is mitigate what I think are the downsides of current payment systems because they're not aligned appropriately. So I'll leave that editorial. We can have some more discussion about that later on. All right, I'm going to stop there in the interest of time. And there are other slides that you can refer to in the presentation. And I think we'll stop there. Thank you.
We will have time for final questions and discussion at the close of our last speaker, Dr. Ken Ottenbacher, who's going to be talking about observational analyses using secondary data. Ken is the professor and director of the Division of Rehabilitation Sciences and also director of the Center for Rehabilitation Sciences at the University of Texas Medical Branch in Galveston. And he also directs the R24 Center on Rehabilitation Research using secondary data. Ken.
Well, thank you, Alan, and good morning, everyone. I'd like to begin by, first of all, thanking Alan and the faculty and staff at the Health, Disability, and Research Institute for inviting me here this morning. So I'm going to kind of continue our discussion about this research continuum. Gerben showed a slide with a continuum from RCT effectiveness studies, efficacy studies, through observational cohort studies, and I'm going to talk to you a little bit about secondary data analysis. And I'm not going to spend any time trying to argue philosophically about causation or association because it's a very complex argument. And you know, scientific truth is a consensual thing. It doesn't happen from any one study. No one study is going to give us the truth about science. And I'd suggest for those of you who are interested in this argument, the readings by Lee J. Kronbach or John Zimmerman, Public Knowledge, or his follow-up book, Reliable Knowledge, have wonderful discussions of these issues. So just to start off with a definition of what secondary data analysis is. And this is a definition by Sarah Bosloff, and there's a couple of references below the definition. So this defines, and there's a number of, secondary data analysis involves a lot of different things. So one way to describe it is the person performing the analysis did not participate in either the research design or data collection process, and the data were not collected to answer specific research questions. And again, there's a couple of references there. I'm not sure if the slides are going to be posted on the website for the center afterwards, but at the end of my presentation, I have a slide with a URL that if you'd like to download my PowerPoint presentation, you can do that. So the advantages, a couple advantages of secondary data analysis. The first one, the main one, is economy. So the nice thing about secondary data analysis is someone else has already collected the data. And that is a huge savings in terms of both time and money. So that's just a huge advantage. There's also the scope and breadth of the data available. Examples like the U.S. Census is, you think about information that's collected representing the entire population. And one of the advantages, again, of some of the secondary data analysis is that in some cases you actually can study entire populations. You're not limited to a sample. So that this issue of scope and breadth of the data available. The data collection process often includes high levels of expertise. The census data is an example. The NIH and other agencies have large data sets that are available. I'm going to give you some examples of those in a couple of minutes. And the people who have collected those data have gone through a lot of trouble to make sure the data is well collected and well categorized. The size of the sample and representatives of the participants, that's another advantage. As I said a minute ago, sometimes you can actually study everyone in a population using these methodologies. And the last one, large data sets allow sophisticated analysis. Because you have such large numbers, you can look very closely at subgroups You can look at trends over time, and these are significant advantages that you often don't have in smaller cohort studies or in RCTs. But there are also some major disadvantages. The one that I think is probably the most limiting is this fact that you're limited to existing variables. So you're not doing this prospectively. This is retrospective analysis. So if you have a specific question or a specific variable that you want to collect and it isn't included in that data set, well, you're just stuck. You're limited to the variables that were collected originally. Sometimes the quality of documentation isn't clear. Sometimes the data control issues aren't clear, again, depending on the source of the secondary data. Doing secondary data analysis requires specialized skills, and I'm going to say a little bit more about that later on. And they're not the skills that we generally learn as rehabilitation investigators or disability investigators. So it does require a special set of skills. Now, a lot of times I think people focus on the sophisticated statistical analyses that are done that are reported in literature, and those are very important. But the data management that's involved in dealing with these very large data sets, if you're talking about data sets like the Medicare files, and there's literally hundreds of thousands, millions of records that are in those files, and managing that data is a very complex, difficult thing to do. And it's not something that is included generally in the research training for most investigators. The availability of the data is also an issue. Many of the data sets, the secondary data sets that are supported by the NIH or other federal agencies are publicly available. But there are other data sets that you have to pay for. The Medicare data, you have to pay for the data. So the availability of the data, the privacy issues associated with these large data sets, with the HIPAA regulations and all of those things are also, can also be quite complex. And occasionally the information is outdated. So those are some of the challenges in terms of using secondary data analysis. But there are huge opportunities. Particularly over the last 10 years or so with the advances in both statistical procedures and more so the computing and the availability of the internet, there's just a lot of information that's out there now. And people refer to this as big data. And I'm not going to read through this quote, but this is from an article that was published in Science a couple of years ago, well, just last year actually, and talking about how this is a revolution in data analysis and our ability to look at information because of the resources that are available through the internet and through technology primarily. And for those of you who are interested, there are a number of references. Everyone's heard about the cloud and all of the information that's out there in the cloud. Well, the cloud is part of big data. And big data is something that's here to stay, and the data is just going to keep getting bigger and bigger and bigger. And we, as disability and rehabilitation investigators, should take advantage of that. We should figure out how to use this data, how to take advantage of it, because there's information in that data that can be useful to us in answering the questions that we think are as important. One example, as I said, everyone I'm sure is familiar with the cloud. How many of you have heard of the WALDO, the Wide Area Large Data Object? So this is a digital archive that is optimized to handle real-time data. So for folks who are collecting sensory data, so if you're collecting heart rates or you're having people wear sensory monitoring devices, accelerometers, mobility, that data that's collected real time can be put into data. So that's a huge amount of data when you think of how that data is collected. And how do you manage that? How do you analyze that? How do you deal with that? And so people are struggling with those kinds of issues and how to just collect, how to archive that data, how to make that data available. Oftentimes when I'm reading or thinking about this, I'm reminded of these lines from T.S. Eliot's poem, The Rock. The first part of this is, where is the life we have lost in living? Where is the wisdom we have lost in knowledge? Where is the knowledge we have lost in information? And with apologies to Eliot, I want to add, where is the information and knowledge that we have lost in data? Because there's so much data. These data sets, these secondary data analysis opportunities reflect a real challenge to us in terms of how to deal with this. So I want to just talk real briefly about a couple of potential applications. One is establishing system outcomes. So I talk often to our students about system outcomes versus personal patient outcomes. So things like the health report cards, I'll give you an example here in a minute. Using large data sets, doing secondary data analysis can contribute to the healthcare reform activities, the Affordable Care Act, and I'll show you an example of that in a minute. And also the national quality indicators. The national quality indicators, the National Quality Forum, are becoming a major issue within rehabilitation and disability. And we really should be paying attention to this. I mean, this is going to affect how we practice and how we're reimbursed and affect our outcomes in a lot of different ways. And we should be involved in that process. So I think most of you are familiar with the health report cards that are available through Medicare. So Medicare now provides information through Nursing Home Compare, through Home Health Compare, through Hospital Compare. There isn't an IRF Compare yet, but clearly the trajectory is that there will be one. And obviously we're talking about comparative effectiveness research, and comparing outcomes across different facilities is an example of that. This is information from the home health agencies, the Medicare Home Health Compare, and it shows comparisons for outcomes that are functional outcomes that are collected from individuals that are getting home health services in this case, and it allows comparisons from that facility to the state facility and to the national average. So if you want to go to Home Health Compare, you can look up any home health agency that gets federal money, that gets Medicare money, and compare their outcomes to other agencies in your state, or compare to the state average, or compare to the national average. And that's big data. I mean, that's secondary data. Alan already mentioned this, the Comparative Effectiveness Research, the IOM report, and we're going to hear later on about the PCORI, the Patient-Centered Outcomes Research Institute. They're obviously putting lots of resources, the NIH, the federal government. PCORI is a new institute that's formed through the Affordable Health Care Act. Data sources, there are many data sources. I think most of us in rehabilitation would be amazed at the number of data sources that are out there. We're just not aware of the number of data sets that are available to us. And this is just a small example of several of the sites where you can go to find out more about data sets that are available to you. So PCORI, just since we're talking about patient-centered outcomes research, PCORI, and Alan mentioned this earlier, has been quite interested in methodology. In fact, just earlier this month on June 4th, there's a PCORI methodology committee, and they've been charged to develop a report about methodologies related to comparative effectiveness research, particularly patient-centered comparative effectiveness research. And they just issued a preliminary version of their report on June 4th. So I'd certainly recommend to you that if you haven't seen that, to go online and look at that. It's again, a preliminary report, but it's very comprehensive, and it talks about the different methodologies being used or being proposed, their applications for comparative effectiveness research. And I wanted to just mention 3 areas in there because they have to do with secondary data analysis. One is electronic health records. So this is another new area where the data that's available in electronic health records and linking electronic health records across facilities is something that PCORI is interested in, and the methodology committee actually talks about data analysis networks and registries. So again, as a resource, the standards in the conduct of registry studies for patient-centered outcomes was a report that was subcontracted through, I think, the University of California at San Diego and RAND for PCORI to talk about methodologies related to secondary data analysis, and particularly using registries. And there's examples of a couple of registries there. So again, looking at registries to do secondary data analysis. This is one related to distributed data networks. So distributed data networks, there are a lot of distributed data networks out there. Some of them are relevant to rehabilitation. Again, there was a sub-report to the PCORI methodology committee that talked about standards for using these distributed data networks in comparative effectiveness research, and it's an excellent resource. And the last one that I wanted to mention just real quickly is the National Quality Indicators for Inpatient Medical Rehabilitation. So the NQF, everyone's familiar with the NQF, National Quality Forum. So if you're not familiar with the NQF, you should go on their website and look at what they're doing. The National Quality Forum is involved in setting national quality indicators for healthcare, and they've developed some for post-acute care. The initial ones were presented in August of 2011 in the Federal Register, and they included new pressure ulcers and incidents of catheter-related urinary incontinence. So it's clearly important to look at these quality indicators, because again, if you go back to this, the Medicare, the Home Health Compare, and the Nursing Home Compare, if there's going to be an IRF Compare, it's going to be related to these quality indicators, right? So we should be paying attention to these. There's a couple others that are on the list to be added. One of them is hospital readmission. Hospital readmission is a big issue in healthcare reform and acute care right now. And I think most of you know that the Medicare now has a system in place for hospitals. If you have hospital readmission rates that aren't appropriate, you can lose money. Most of that research has been focused on acute care hospitalization. But hospital readmission within inpatient rehabilitation facilities is, I think, an area of concern. The patients that go to inpatient medical rehabilitation facilities, individuals with stroke or hip fracture, are at a high risk for hospital readmission. And no one's really looked at them very much. And that's clearly on the radar for NQF and others as a national quality indicator. It's an area that we've been interested in looking at. Within CMS, I would hope most of you are aware of this. There is a file in CMS, the Inpatient Rehabilitation Facility Patient Assessment, the IRFPI files. Since 2002, Medicare has been collecting data from IRFs, and they have a separate file within the Medicare system that's just rehabilitation information. It's all the FIM items that were licensed into the IRFPI, and then a bunch of other items, and that information is available through this file through Medicare. We've been interested in looking at this issue. This is rehospitalizations for IRFs based on stroke and fractures for the first 30 days. 30-day rehospitalization is what they're interested in acute care. And it's kind of interesting to see that most of the hospital readmissions occur in this early period, within the first week to 10 days. And one of the things that you need to have to set this up for inpatient medical rehabilitation is a standardized rehospitalization risk rate. You need to know what the national level is. What is the hospital readmission rate across IRFs for the nation? And so we're interested in looking at that because that's kind of a baseline for doing comparative effectiveness types of studies. And again, rehabilitation investigators are not trained in how they learn how to do research to do this kind of work. They're trained to do prospective, patient-oriented trials, and that's the way it should be. We're a clinically oriented field. That's the kind of research we should be taught, we should learn how to do. But it's also important, I think, that some of us know how to do this, and some of us know how to deal with big data, some of us know how to do secondary data analysis, some of us have an interest in doing that. So our center, our R24 center, is designed to help do that. So we have an R24 center, the Center for Research Using Large Data Sets, and it's really a service center. It's a service center for you all, for investigators and research in the field who are interested in doing secondary data analysis. And if you are or have ideas and need help, then you should contact us because we have things we can do to help you. And I think we'll have some flyers, and there's a couple of folks from our center who are here, and we'll have a table, I think, at the where we're going to have lunch. We'll have some more information about the services we have. So I'd like to end. This is a quote that this is an aphorism, I guess, that my major advisor when I was a PhD student, that doing outcomes research is a lot like raising children. You always think you're going to do a better job next time. And I think we can do a better job next time if we take advantages of all the methodologies and the menu of procedures that are available to us. And using secondary data analysis is one of those. And I would like to argue that it should be an important part of our armamentum of research skills. So thank you for your time, and I look forward to interacting with you the rest of the day and learning more about comparative effectiveness research. Any of you who would like to know more about our center or our services, please let me know.
Okay, we have about 10 minutes, and so we'll open it up for comments, questions, or discussion from the audience that can be directed to any of the speakers. And again, please use the microphone.
Hi, Amy Klein, actually from right around here. And my question is for you, Dr. DeJong. I was interested when you said that many of the patients in your studies went on to home care and to outpatient therapies, both PT and OT, and recognizing the differences in the intensity, which I was pleased to see, from the IRF to the SNF. Did you find in the end that there was no difference because of the subsequent care that each of the groups received, and not just based on their individual initial setting? because of the criteria to go into an IRF versus a SNF?
What we did find was that some of the outcomes were durable, but they were moderated over time. And so that over the long period, the differences started to wash out, very much so, because of the additional services that people received. Right.
Hi, Alok Kapoor, Boston University. Really appreciated the talk on the secondary data analysis, Dr. Ottenbacher. You mentioned some of the data sets that are out there. Can you talk a little bit about other sort of emerging trends and data sets that might be available, particularly in the post-discharge setting, because most of the sort of catch-all databases are focused on acute inpatient care, and to really get all-payer outpatient database type registries or administrative data sets, that would be obviously the ideal in comparing to other countries that have national health systems. So maybe talking about that, what movements. I think North Carolina is one example of having an all-payer outpatient, but there might be others that you're aware of, and then particularly focusing in on rehabilitation. Post-surgical is my particular interest, given that home care agencies don't uniformly report to, not all their patients are going to be covered by Medicare, Medicaid.
Right. Well, it's a very broad question. There are literally thousands, probably tens of thousands of databases that are out there. So one of the things that we've elected to do with our center is to develop a data directory. The idea being that if you have a question that's you think might be amenable to doing secondary data analysis of large data sets, you could go on Google and start looking for, typing in whatever you wanted to do, and you probably find things. But it's kind of hit and miss. So one of the services we thought was important for our center was to create a data directory. So we have a data directory. If you go to our center website, there's a data directory, and we've, I don't know, Amal, how many data sets do we have on there now? 40? 30 or 40? So and we did actually a survey using the model systems, the NIDR model systems folks. I mean, they're obviously national data sets that exist with the model systems, and some other groups, just looking at if what are the data sets that would be useful to you. So our data directory has information. You can search it a couple different ways by a disability area or a general topic, and it has information about that data set. What variables are in the data set, how it was collected, how you get access to it. Is there a fee for it? So it's basic kind of information. So I mean, that's not a specific answer to your question, but we're trying to develop resources for investigators that are interested in doing large data set research and find the rehab-related data sets that are the disability-related data sets that would be most useful to them, of most interest to them, and have a place where they can go and find out about those data sets. So I would invite any of you who are aware of data sets that you think would be useful to the field to contact us, because we're actively in the process of putting that together. We have a relation, one of our consortium partners is Cornell. And if you go onto Google and you type in disability data sets, you'll probably come up with disabilitystatistics.org. So the disabilitystatistics.org group at Cornell has been putting data sets together for a long time, but they have an employment focus. That's what they do. And it's a very well-developed site. They do reports. It's a very impressive site. So when we started our center, rather than reinventing this whole process, we partner with them. So we identify the data sets. We get the basic information, then we pass it on to them, and they load it onto our site. And they do a very nice job of describing the data sets. So it's, again, providing resources for people who have a specific interest in a resource that's in a localized place. So I hope that's helped.
Yeah, I'd like to add, the microphone on? Yeah. I just want to add to that. One of the things I've noticed, and maybe it's just my perception, and others around here might correct me on this, but when it comes to clinical registries, for example, I think other countries probably do more of that kind of thing. For example, it's taken us forever to get a registry set up for hip and knee replacements, even though we do more than 1 million of them a year in this country, and we're scheduled to do 3 million of them a year in another 15 or 20 years. But whereas other countries like Australia, Sweden, and others have such registries, and generally I think it's tied to the nature of the health system that they have. And I suspect, I don't know if others of you have thoughts on that, but I think we may want to also, when we look at specific clinical populations, is to look outside of our own country to look at other clinical registries.
Ruth Brannon from NIDAR. I have a question that I think several people up there would comment on, and it's taking a step back, and it's reflecting on experience I had a couple of years ago working, and Lou Cotrano was a part of the group, and we were putting together the Rehab World's recommendations to the IOM for interventions that might be considered on their list. And the issue was what rose to the level of being an intervention that had been, that was ready to be compared. Where were the comparison groups in rehabilitation medicine? And we came up with a list, and none of them actually made the 100, though there are things around the edges. But the dialogue was about the fact, and it's in the literature. I mean, I read some of Lisa Iazzone's work and other people's work in preparing for this, that there are very few proven interventions. So I have a threshold question, which relates to the methodological approaches that you all talked about, which is, how do you think we will establish, or how should we as agencies, because we're going to be implementing these research programs, establish the level of that has to be proven for something to be an evidence-based practice that's going to be compared to some other evidence-based practice. And it's an issue for agencies like NIDAR, which have a limited amount of resources, and we have been investing in the development of interventions for a very long time, moving things along. But this push to look at comparison of effectiveness for an agency like ours is going to mean moving resources, if we went that way, moving resources from one area to the other potentially. And I'm just curious, does the threshold of demonstrating effectiveness or efficacy before effectiveness, how do you deal or think about that as you talk about your methodologies?
Well, I think that is a really fundamental challenge. I think that there are a number of questions that are part of that need to be considered. For example, when we're doing these comparisons, are we really wanting to determine the superiority of one intervention compared to the other? Or are we wanting to just determine is something basically equivalent to what is existing, what is the really widely established practice? So is it non-inferior, or is it actually superior? I mean, I guess one thing that you could argue is that if we have very, very widely used interventions and somebody comes up with a new way of delivering them, a different approach to it, do we need to first establish that the one do we need to establish the effectiveness of the one, or is it important to compare what is the widely used approach, whether it is non-inferior or superior to the new approach? So I think that's one point. Do we need to have unequivocal efficacy before we do a comparison? Then the next question is, for the interventions where we want to say we have two where we're wanting two potentially efficacious interventions to compare them. I think that it is going to take, that is going to be a challenging question that we're going to need to look at synthesis of the literature and get groups of people together like this potentially to argue out. I think it is the reality that there are dollars attached to doing this research, that we can't do every single, the perfect RCT for every research question. And I mean, I think PCORI did take did show an approach of looking at a very wide range of things, looking at the data that's out there and coming up with a list. And perhaps within disability research, we need to have an intensive focus and a group to work on creating a list just for that. I guess that's my answer.
We are out of time, so I'm going to suggest that we break until 11 o'clock, and I would encourage you to continue your questions and discussions among yourselves and with the panelists during the break. I want to thank, I'm sorry? I didn't see, I'm sorry. So I want to thank the panelists for their excellent talks and for really providing us with a lot of stimulating information and provocative ideas to further our discussion. Thank you. We shall reconvene now. I want to welcome back everyone who's on our webcast today. Thank you for joining us. And thank everyone for returning from break. Our next speaker is Dr. Tony DeLito. Tony, among other things, is professor of physical therapy and chairman of the Department of Physical Therapy, as well as associate dean for research in the School of Health and Rehabilitation Sciences at the University of Pittsburgh. He's also an avid baseball fan and was with us last night, and his priorities on occasion are misplaced, as they were last night. But we're delighted to have him here to talk about diagnosis and classification in CER research. Tony.
Well, thanks, Alan, and your colleagues for inviting me here. It's a real honor. I feel as though I should start off by saying that my name is Tony DeLito, and I haven't done a randomized trial in 3 years. but actually, that would not be quite truthful. We are doing one now and planning one, but I will tell you this, that I did shift my emphasis quite a bit in my research career from doing the efficacy, effectiveness types of studies to actually trying to do or attempting to do implementation studies, and then trying to demonstrate the fact that I think the real challenge for us now is in the implementation area. And that's what I think that's why I'm up here, to talk about my experience in that. I had a revelation in around, it occurred around the late 1990s when I had the attitude going into doing research in this field that if you built it, they would come. If you built an evidence-based practice, all you had to do was publish the work and it would work. It would happen magically in the clinic. And I found out the hard way that the real task ahead of us is getting things implemented, and that's what my research has been around. Alan talked about where I'm from at Pitt, and right now we're in the midst of trying to take advantage of some of the reform opportunities that are out there. And what we've really I've centered my attention around is this value and the importance of demonstrating value. And I need to put this up front because this is really what's driving what I want, my research and the direction of my research. And I think it really does provide research directions for all of the rehab professions that are in the room. And I think, as we've heard earlier now, it's more than just effectiveness for all, but I think we have to, I truly believe this very strongly, we have to broaden our perspective, and we have to identify the patients where we are the most valued. And I think that it gets to the question earlier about prioritizing. And it's a little bit of a different way, and it also leads me into this diagnostic research component. Because a lot of the work I had done previously in the area of classification of low back pain is related to doing diagnostic type studies or using a diagnostic process. Now, Alan, as I said earlier, spent a lot of time telling you about all of my roles at the University of Pittsburgh. But in reality, What I'm going to be talking about are really my roles outside of the university and within our health system that we have created at the University of Pittsburgh, namely this 400-pound gorilla that we have called the University of Pittsburgh Medical Center. And we are what in the reform world is called a integrated financial delivery system. And it's very interesting. When you create a system like this, you begin to start actually being able to implement the kinds of things we've talked about. And I think until we create systems like this, we have too many competing issues going on that make it much more difficult to do implementation types of research that are based in value. The two areas that I want to focus on are, I have a role in the Centers for Rehab Services, which is the largest physical therapy and occupational therapy and speech therapy provider for the UPMC. Now, the University of Pittsburgh Medical Center has 55,000 employees, 8 acute care hospitals, and we have 42 outpatient clinics, 4 specialty programs. We have APTA credentialed residency programs. We have over 300 therapists. It's a large integrated system, and we are the provider for this, the rehab provider for this integrated financial delivery system. It's very important to understand that once we're networked, we are much more easily able to implement some of the initiatives that we put forth. We also, I think the real other key player is our payer. We have a health plan. So suffice to say that in the old days, when it was run up the bills as much as you can and charge the insurance company, when you put a system like this in place, you now begin to realize you're taking the money from the left-hand pocket and putting it in the right-hand pocket. And you really can much more seriously discuss reform, efficiencies, and what's best for patients. So I'm going to talk more a little bit about diagnosis, and traditionally this is the traditional diagnostic study. Over here, you have study participants, they come in, we have a target disorder that traditionally most people look at as identifying some kind of disease. Then we have tests that are positive or negative, and we look for true positives and true negatives, and of course we want to minimize these false positives and false negatives, and we have all sorts of statistics we can run on these kinds of tests that tell us. And then we have good studies where our reference standard we're blinded. There's all sorts of things that go on in studies like this. And what I'd like us to do in this, for the purposes of this discussion, is to start to think about refining what we call our target disorder or our reference standard. Okay? And if we refine this, we can take all of the diagnostic study techniques that we use and use them to our advantage. And I'm going to try to relate to you how I believe this relates to comparative effectiveness research. So sometimes that target disorder can be responsiveness to certain interventions, and this is what we learn as clinical prediction rules, and we've found this to be a very effective means of identifying treatments where patients are responsive, or we identify characteristics of patients who may be more responsive to certain treatments than others. This has been especially effective in the area of low back pain, where there really isn't much else to guide a person in terms of treatment. So, and the other area that I like to focus on is sometimes the reference standard can begin with just simply the simple question, who are our costly patients? And what sorts of factors predict who's going to be a costly patient? And for example, we know in back pain, less than 10% of the people that we see, at least from studies that are out, are responsible for 80% of the costs of what goes on in back pain. So perhaps we want to look at this as a target disorder and through some sort of diagnostic process, try to see if we can predict beforehand who the more costly patients are. And those are two examples, and I'll go through some specific examples of how we've looked at that in our system. Well, I don't need many slides to convince, I hope, people in this audience to know that back pain is very expensive. And it's inordinately expensive, and for the most part, people will have asked the question, why do we need to spend so much money on back pain? I think it's very clear. These are numbers this is a 2010 estimate, and and we see this less than 5%, 75% of the cost. Usually, no matter what study you look at, it's a low percentage of patients who are responsible for a high proportion of the costs. Now, it's no different with us, and it's especially important that you realize that on my role in the health plan, I'm part of a musculoskeletal subcommittee. And it's very important that I bring to the table my knowledge of research and epidemiology and everything else, but I really don't need to, because they look at their own data and the health plan, and they realize that, wow, low back pain is costing us a lot of money. It cost us $6.2 million on just 937 cases in 2009. That is a disproportionately large amount of money. It's the third largest cost bucket in our payer, behind neoplasms and cardiopulmonary disorders. So when you think about this, you know, again, these are insurance executives and health economists who work for our health plan who come to us because it's a provider-led health plan, and they come to us in my role in the musculoskeletal subcommittee, and they ask a simple question: why are we spending this much money on people with back pain? A lot of these people are our own employees. So it's a problem across the U.S., and if I were writing an NIH grant, I would use this. But in my role in the health plan, it's a mirrored problem there. So we asked the question, well, where is the money being spent? And again, there's congruence in what's happening across the country, as well as what's happening right under our nose in our own system. Okay, unnecessary imaging, a lot of procedures, excessive pharma. And I can pick on all the other professions here, but I'll also pick on my own profession. Not adherence to best care standards in our own environments. So we have excessive use of physical agents, passive agents, and things like that. We actually, in our system, are guilty of this. So when we look at our data, we see this, and so there's a lot of room for improvement here. And I'll put to you in this audience, we could have evidence-based practice courses until the cows come home, and bring every one of our therapists in. And we can turn around and test them all. And they'll tell you they have the competency to understand what's out there. Yet we'll still see this behavior. And I have my own opinions of why this happens, but the major one that keeps coming to the front is the finances aren't aligned. That's the bottom line. And you need not look any further than the Medicare fee schedule, and you'll see. There's 5 different ways to charge for those passive modalities, right? Now, if we define our reference standard and redefine it, right, to this upper 25th percentile of costs, we can now begin to look at our data a little differently, okay? And I want to focus on 2 ways of looking at it, okay? One is, what variables predict the upper 25th percentile of costs within our rehab environment, and then what are the external factors that predict these costs, okay? And it's very simple for us. With us, when we looked at our costly patients, and we looked at the internal factors within rehab, we looked at a simple question of, does adherence to best care standards in the rehab environment predict the upper 25th percentile of costs? In other words, when we provide decent care, or what we would consider on-protocol care within our physical therapy environment, right, and compare that to when we don't provide it, this is taking advantage of our bad behavior, okay? We actually look at when we have provider care that's not up to standard, does it predict that upper 25th percentile of cost? Okay, and this is one way to look at a diagnostic study. So and the other way of looking at it is, because we can combine our information with the data that's available in other places, what are the comorbidities that predict these upper quartile of costs? In order for us to do this kind of work, right, we have to create the database ourselves within the intra-rehab environment. That doesn't exist. It didn't exist before. So, I don't know what's happening here. Okay, but anyway, so what we have to do is formulate this clinical database, and we formulate it based on evidence-based practice principles, okay? We have to collect this over a period of time, and we have to make sure it's very comprehensive. We can't be accused of cherry picking. And we have to then evaluate our therapist's compliance to putting the data in the database in a complete format. their adherence to best care standards. We have to define what those best care standards are and see if they're adherent to them, okay? And then we also track outcomes. We would like to do a better job of this last piece, but that's a work in progress. But for these first two pieces, over a period of a couple of years, we've been able to do this. We've been able to get data. We identify ICD-9 codes that relate to low back pain. We make sure that our therapists are over 95% compliant. Every time we get a patient who comes in with one of those ICD-9 codes, we get a completed data set on this minimum data set, okay? We then have come up with algorithms where we look at adherence to best care standards, and we look at non-adherence to best care standards. And then we can go to our health plan and see what kind of prediction value some of this on-protocol versus off-protocol status has with regard to predicting upper 25th percentile of costs. This is one of the pieces of information that I like to say, take care of our own house. Provider adherence to best practice and measurement of provider performance is one of the intricate variables that we need to look at when we're trying to show value. So it requires rehab process of care data, adherence in the trenches. It's more than claims data. Claims data is meaningless here, guys. You can't really get into look at this in a granular way with just claims data. And it's an opportunity. It's also an opportunity for us to help design electronic medical record components that we are going to need. So is protocol adherence a strong predictor of unusually high costs? Well, we look at this in a very standard diagnostic process approach. We look at, as I said before, our adherence is based on algorithm-based rule sets, and we do this very, standard approach that you would do in a diagnostic study, okay? And the answer is yes. A non-adherent care is 1.5 times more likely to end up in the upper 25th percentile of costs. And immediately, the evidence-based practice people in the audience are going to look at this and say, whoa, look at this confidence interval here. I don't know about that, And you're right. It's from a strict adherence to evidence-based practice standard, you'd say to yourself, well, I don't know if that's really enough. But I have to ask you guys, what's the threshold for action here? And the threshold for action as far as our health plan is concerned is, yeah, it looks pretty good to me, because when we also did some other analyses and we looked at adherent versus non-adherent care, we found that non-adherent care ended up costing us about $250,000 more downstream after the person left PT. As far as the threshold to action for our health plan was concerned, we met it. As far as the threshold to action for others, it's debatable. Now, what about other rehab factors? Well, it seems as though I put diabetes and obesity up there, because when we have somebody who sees us with low back pain and they also present with diabetes and obesity, they are 10 times more likely to be in this upper quartile percentile of costs. And in this situation, you have to trust me when I say that these are low back pain related costs. This is in addition to all the other costs these people these two comorbidities lead toward. All right. So again, a threshold to action here, it gets us thinking, what should we be doing in the rehab environments? So I think what we're driving at, what we're trying to drive at is, this represents the total amount of money that we are dealing with. We have a good proportion of this procedures, a good proportion of it imaging, a good proportion of drugs. These three areas we know we're overutilizing, right? And we have these rehab charges that are here. We actually have made the case that we may want to increase the amount of money we're spending in rehab on patients, but only if we're going to decrease, if it leads to decrease in these other costs, okay? And in order to do that, we have to make the case that we're going to clean up our own house. In other words, if people are going to divert patients toward the rehab environments, then it would be much more effective in our argument if we were to say that we are more adherent to best care standards. And I think this slide there's a few points to make with this slide that I think get to the crux of the issue. This represents, this circle does not represent money. This circle represents encounters. Okay? Every time a person with back pain sees someone, that's an encounter with someone. Or every time they utilize a service, that's an encounter. And right now, the physical therapy component is a smaller piece of this pie, and most of the larger pieces of the pie are everything else, everywhere else they go. And the idea is to shift the encounters, increase the piece of the pie, and again, we're relatively inexpensive compared to these other things. And of course, while we're shifting people to this component, we are putting in place procedures that better assure adherence to best care standards. And the thought is that there would be less encounters with these other more costly procedures. So this is an inexpensive way to go. There's a quality component to it, and it really does define the role of evidence-based practice and what it is we're doing. Okay? Now, encounters, what we think has happened in the past and what's happened in our experience in the past is that the attempt to try to decrease encounters itself, which is what a lot of guidelines have advocated since the mid-90s. Don't do this. Don't send them here. Don't do this. Back pain will get better on its own, right? What we realize is that as soon as you give the patients, that approach may have worked if the gatekeeper component worked, and if the primary care physicians truly could be gatekeepers. But what we realized was that patients don't settle for that. And as soon as you give patients expanded choice, they won't listen to someone who says, you're going to get better, don't worry about it. They're going to go somewhere else, and this is what they've been doing. And again, we can track our data to see that. You know, a very large percentage of our patients, within a week of seeing their primary care physician, were off seeing someone else. And this is what happens. We had adherent care on the primary care physician's part, but we didn't have it wasn't working with us in our system. So this is I think encounters becomes the key here. Because when you decrease encounters, that corresponds to rationing. And when you can keep your encounters up, and you're likely to keep the satisfaction of the patients higher. It also points to another area that I think is important, and the other area is this notion of, we were just talking about it, the interprofessionalism and the role of these advanced practice professionals and the acceptance of advanced practice professionals as a solution to some problems within the system. And I think that's another thing we struggle with in our system. So that's my talk. And what do we do? Questions or questions?
I was just wondering if you had an independent measure of adherence, and how did you measure adherence to best practice or best care?
As independent as algorithms that are written in a program are, I don't know if that, you mean the data comes in, it's electronic, and there's a lot of if-then statements based on the data that's put in. It's not, there's no judgments involved. The judgments were made in the algorithms previous. But other than that, is that?
I was just wondering if you had, say, an expert practitioner.
Oh, I see.
Observing to see if it was best practice care.
No.
Really interesting talk. Thank you. I had a question about the non-adherent care in the sense that a disbeliever could easily say that these clinicians made specific judgments about individual patients who would not do well with the standard care, and that's a particularly vulnerable argument given the criticisms of RCTs and group studies that ignore individual differences, blah, blah, blah. So do you have ways to look in your data set, for example, is this a particular therapists who deliver non-adherent care a lot versus every therapist delivers it to a few patients? And how do you explore whether it's truly the wrong care or those are really complicated patients?
That's a great question. First thing is we have a gray area in the middle that we leave out. So the non-adherent care is, I think, you'd have to take my word for it, but it's the kind of care that I would put in front of anyone and they would say, this is not good care. lots of passive agents, lots of almost no adherence to any sort of exercise standards, no encouragement to return to activity, ignoring known behavior. We give out fear avoidance beliefs questionnaires to all of our patients. There's thresholds for that, and when they're completely ignored, that would be another area. So I think that's the one. And then the second question was?
Whether you look at patterns of whether it's specific therapists doing a lot of non-adherence, which would tend to imply that it's not judgment about individual cases.
It is, and it is that. It is that. And the other thing I would say to that, though, is I'm very much interested. We are very much interested in looking for what Alan has referred to previously as positive deviance. In other words, is there somebody not adhering to care yet they're getting good results? And the key piece of information missing in our data set right now is outcome. So if we had people not adhering to care and they were getting good outcomes, what I would want to know is, what are they doing? What sorts of things are they doing that are accounting for good outcomes, or even some therapists that you could relate to that may be less costly down the road. So that's another piece I think that is that's clearly missing here.
Tony, have you taken this algorithm to other areas, for example, the knee, where there are so many MRs being done on people that clinically you can assess what their problem is without having additional imaging?
The knee is next on the agenda because the knee is the next highest cost bucket for musculoskeletal disorders. So definitely the knee is the best, is our next area of study. Yeah.
Tony, do you have, and thank you so much for the presentation. But I think UPMC has the advantage of being a closed system, so you can look at downstream costs and downstream outcomes. Do you have any advice for people who don't have that luxury, who just provide PT, for example, services, and don't have as much evidence available as you do to make the case to administrators that PT actually, in the long term, can be more cost effective than another kind of therapy?
Well, I think your next best avenue is what's published out there now, and making some sort of a presumptive argument that what you can do is effective. I will tell you this: what does work with payers, although a lot of them have discovered it themselves, when you can identify you can identify something like in back pain where a lot of expenses on pharmacology, on things that are ordered, and you bring up the fact that in certain environments, these advanced practice professionals can't order those things. The response you get all of the time is, well, I don't really know what it is you're doing, but if we can corral the patient for a little while, take advantage of spontaneous recovery, and the other things won't get ordered, that might be a good thing. Do you see what I'm saying? And that's an argument that I know has been used a lot, and in fact, that's an argument that I know payers have. I think that's one of the reasons why payers haven't really resisted heavily some of the direct access initiatives in certain states, because they see that. Their concern previously about overutilization has now been overridden by the fact that certain environments don't encourage the propagation of testing and things like that.
I have a question about, I really love your model about savings and how increasing rehabilitation could actually be a savings. One of the other big payers is Medicaid and the dual eligible Medi-Medi program. So, and one of the challenges that I have had for people with severe disability who are not going to be recovering is how to demonstrate that rehabilitation could be a savings in a public-funded model.
Yeah.
And I think your example might really help us on the other side of the non-insured or uninsured people.
Right. I think that it's a great question, Kathy, because the Affordable Care Act, if it does move forward, is going to put a huge burden on the states in the area of Medicaid. just because of there's going to be many more people eligible. And I don't think there's obviously not a state in the country that is thinking about how they're going to handle this burden. If you look in our state, rehab is not very widely prescribed in our state. And when it is prescribed, the fee schedule is so restrictive in terms of what you can do that it's almost no good care can happen unless you just do it gratis, above and beyond what's going on with in following the fee schedule. I think that the task at hand is, number one, is partnering with the Medicaid people of your state, and that's one of the databases that our Health Policy Institute is one of the first databases it got hold of was the state Medicaid database. And what we're doing now is partnering with them so that they can learn what the burden of care is, learn where the money's going. When I talked to the head of Medicaid in Pennsylvania, he rolled his eyes when we talked about back pain because the expense is enormous, but they don't know where the money's going. They don't know very precisely where the money's going. We think it's going, in emergency room visits and, a lot of unnecessary care. And that's what, once you determine where the burden is, then I think you make an easier argument about shifting some of the money, even if that means in one silo the money's going to go up. You can make the case that it's going to come way down in some of the others. And then what you have to do is you have to do it. You have to put your money where your mouth is and actually do it.
Yeah, no, I don't know if Alan's going to talk about that. To me, that's moving more to population-based rehabilitation. And I'm just curious if maybe he wanted to comment on that.
If I want to or Alan wants to. I think Alan's going to comment on that.
No, I'm actually not right now. I think we should stay focused on questions to you regarding what you presented.
Okay. Did you have one? Go.
I do have a question, though. The model that you described seems to work extremely well in an area where you have a pretty good sense of what best practice should be. What do you do in the areas where it's not nearly so clear? And then how are you handling it in your system? Because the problem is obviously, I know this will come as a shock, but it's broader than low back pain.
It's a great question. I think the first thing you have to do is you have to accurately characterize the status of practice as it stands right now. We always look to evidence-based practice in an attempt to try to optimize practice. And when we look at practice as it exists now, we all admit that we're far from even average in what we're delivering. So again, it gets to this threshold of action. Sometimes a threshold of action is just a consensus about what we do with certain patients at certain times, even when the evidence doesn't back us up, so that we reduce the variation in care. And that's our first step. Where we don't have practice guidelines or strong practice guidelines, we have people who certainly have people who have opinions, and we have people who can come to a consensus opinion about what best practice ought to be, and we need to characterize what best practice is and learn to measure it, at least the best practice as it exists today. And then you go through an incremental approach to that. You have some historical data about how bad or what practice is at one state. You implement something that maybe the goal is just reducing the variation. We know from evidence-based practice, reducing variation does improve costs, improves outcomes, and so forth. And then I think from there, if the database is constructed properly, you can look for best practice to maybe emerge from that. And then you implement whatever that might be to see if it actually can, changing people over from, to whatever the newer practice you discover, if that verifies that best practice is happening. And you just go through it as with an incremental approach. I think you have to decrease your threshold for action with something like that. You really do. You have to, depend on consensus opinion, and actually implement it. But that's, to me, a very viable way to do it. I learned a lot working with our health plan. We have a health economist in our health plan that I work very closely with. Her name is Pamela Peel. Now, Pamela could sit here and trade punches with the best of the evidence-based practice people in the world, but her job at the health plan is to tackle these issues. And when we went to her and said, you know, this confidence interval doesn't look that great, she looked at me and just laughed and said, yeah, but, you know, 0.10 is pretty good. It's all right to act on, especially when, you know, the return on the investment might be pretty high. And then she made the comment that Toyota didn't get to make the best cars in the world by doing randomized trials. They did it through this incremental process of quality improvement. So I think there's something to be said for that. At the same time, there's this academic part of me that really, you know, does want to verify what it is we're doing. Yes?
There's a lot of focus now on patient-centered care and patient preferences. How do you integrate evidence-based practice with patient preference, and what do you do if the patient doesn't want the evidence-based practice?
The low-hanging fruit in that area is what I would consider shared decision-making on the part of the patient, giving the patient accurate information. For example, when a patient sees a surgeon and they have back pain, they get, regardless of even the best surgeons in the world, they get the surgeon's opinion of the likelihood of success, the surgeon's opinion of risks, and so forth. And all of us in this room would, even the best surgeon in the world, would probably say that that is not accurately depicted 100% of the time. Okay? So somebody coming in who doesn't have a vested interest, who can give them these accurate pictures that are evidence-based, okay? And then, in the long run, what you hope for is that that patient, and I've seen this happen if they've been given accurate pictures, will change their mind about something they were insistent on before. You know, the comment back is, well, if you don't think an MRI is really that important right now, and I'm going to get, and you know, and there's always something I can do later on, then they won't be so insistent on an MRI at that point in time. You know, patients who get more accurate depictions about risks will make different decisions about surgery and things like that. And that I don't think you're ever going to stop the patient who comes in and just, you know, you're not giving me an MRI, therefore you're rationing care. I think the way the value-based insurance design is approaching that is to, you know, make that co-payment a lot higher when it's not indicated. In other words, they're not really withholding care, but they're going to have the patient have some skin in the game in doing that sort of thing. And actually, on the other hand, reduce the co-pays for more value-based things. So I think that's how I think those are the strategies that I see being implemented for that sort of thing. And the other thing I think, and just real quickly, we don't expect 100% adherence on the part of our therapists. We expect better than what we're getting, which is between 40 to 50%, but we don't expect 100%. Our database can't possibly contain all of the, you know, potential contraindications, whether they're relative or absolute. For example, if a woman comes in as pregnant, we don't have pregnancy as a checkoff. So there are some things that our therapists can't do with that person that might be adherent, you know, so we rather than go through this exhaustive database where we have all these possibilities, we've just reduced our threshold. We're looking for an 80% adherence rate with all of our therapists. That's what we look for. And we flag them every time they're non-adherent, and they give us reasons back. And some of those reasons are absolutely legitimate, and some are not. Yeah, Carolee.
Thank you. I don't know if this is on. Carolee Winston, University of Southern California. Thank you, Tony, for your wonderful talk. As you march up the chain from the back, or you know, from the hip to the knee, or the knee to the hip, and you get up to the brain, do you think that your model is going to change a little bit, or do you think there's other considerations that have to be taken into account?
Yeah.
I'd like to hear your thoughts on that.
Well, to me, the model starts with what are you measuring in the process of care, and that begins with your therapist and anyone else you can bring in the room. Now, what's near and dear to your heart, for example, stroke. I've been meeting with our neuro-based therapist now for the last 6 months, and the goal which I thought was pretty simple, has become insurmountable, and that's what is a common data set that can follow a patient with stroke through our entire process of care. And we have so many, I like to refer to them intra-rehab obstacles to that. You know, no one's stopping us from doing this but us. And I can't, you know, I mean, you can imagine, and if anybody's done this, by the way, I'd love to have the data. I'd love to bring the data. I'd love to bring the data set forward. Now we're working at that, and we're obligated to get something done because our payer wants this done, and we have to, and we should have it done. We're supposed to be one of these, you know, horizontally, vertically integrated systems that should have a database that follows them, and it's a challenge. But I think that's where it starts. I do. I think your practitioners have to step forward with how they're going to measure their process of care before you can begin to start talking about improvements in a process of care, because you can't improve what you're not measuring. The other thing that's probably the bigger struggle for us, and to me it's the interference, that I'll call it interference, with our regulatory documentation Nazis, who are very, very interested in the audit-proof note being the product of the electronic medical record, and not so interested in this kind of data being a product of the medical record. And I understand where they come from. I do. I understand where they're coming from. But that has been probably a bigger obstacle for me. This whole process that I went through at the back, I did it without telling those people. It's a completely different, and that's not the way it should be, but I did that as a pragmatic approach. And I think that's something we need to, you know, discuss, because I think that's one of the obstacles of this kind of work.
Thanks, Tony. Well, I think you very nicely set up our next speaker, Dr. John White, when you said if you can't measure the process of care, how are we going to improve the process of care? So John's going to solve that problem for us in the next few minutes. Dr. White is the director of the Moss Rehabilitation Research Institute, and in addition, he is professor of rehabilitation medicine at Thomas Jefferson University. John, we're delighted to have you here to talk about defining treatment interventions.
Thank you very much, Alan, and thanks for inviting me to this stimulating meeting. I think also in our last talk, we just got a rigorous test of the hypothesis that observational data is crap. By the way, observational data are crap, but anyway. So indeed, if we're talking about comparative effectiveness, a kind of key question is comparative effectiveness of what? And it's really the treatments that we are seeking to compare in terms of their effectiveness, and yet I think we have a bigger challenge than almost any field in doing this work from the treatment perspective. So I'd like to just cover sort of three basic topics in my remarks this morning. First of all, the importance in general and uses of treatment definition, some of the approaches that have been adopted to date in trying to tackle this problem and some of the challenges they've faced. And then I'll specifically summarize some of the current efforts being pursued by a NIDER-funded project on developing a rehabilitation treatment taxonomy that I'm a part of. I just want to acknowledge the funding from NIDER, and the grant went to Marcel Dykers at Mount Sinai and his colleagues there, and then subcontract to us at Moss Rehab. So it's kind of a Mount Sinai Moss Rehab partnership in this project. Well, let's start with why treatment definition matters. And of course, I probably don't need to spend too much time on that with this audience, but obviously we can't really talk about efficacy or effectiveness of something unless we can define the something we're talking about. But importantly, one can define something well enough to do one's own study, but that doesn't necessarily mean it's defined well enough to allow replication of encouraging findings by other researchers, or obviously disseminating treatments once they've been shown to be effective to practitioners and others. Then also, although we might put this at a somewhat lower priority, to support the clerical functions, coding, billing, and so on. So if we're going to move to administrative data sets, obviously we need a way to capture the treatments in those kinds of data sets in a more summary way than we would do for a research protocol where we have a whole treatment manual or whatever. Well, why is it challenging? Perhaps this is obvious as well, but someone made the comment earlier this morning that we're not mostly doing pharmaceutical research, and that the models have been developed for pharmaceutical research, where everything you need to know is given by the molecular structure, the dose, the route of administration, and the timing, and you're kind of done in having defined the intervention. But obviously in rehabilitation, pharmaceutical interventions, though we do use them, are a small part rather than a large part. We have a lot of use of devices, but those devices have multiple attributes. Should we be defining the treatment as the device, or the treatment as the attributes that the device provides, which may be common to other devices, and there might be two devices that have similar names that have quite different attributes? Many treatments that we engage in are voluntary and interactive or experiential in the sense that the therapist can't fully determine the treatment. The therapist does something, the patient does something back, the therapist then tweaks what they do next based on what just happened. And that obviously makes it much more challenging to define. This is very analogous to what goes on in psychotherapy, where there may be general treatment approaches, but you won't stay with a client very long if what you do has nothing to do with how they respond to what you do. Obviously, in rehabilitation, we didn't just start trying to define treatments with NIDER's funding announcement. There have been efforts ongoing for many years, but they've been challenged for many years. Probably the most common way of defining treatment is simply time. And we have many research studies in the rehabilitation literature that you can look at that analyze outcomes in relation to days of treatment or lengths of stay, things that aggregate at the day level, and then you have a lot of other studies that have to do with hours of PT versus hours of OT. And, you know, as much as we pay attention to those studies and talk about them with a fair amount of energy, the implicit message of them it matters not at all what went on in that rehab hospital, what went on in that PT or OT session. As long as you had an hour together, that was therapeutic. And I don't think any of us believe that, and yet that's the level that we're measuring in many of those studies. Another alternative that's been used quite a bit is what I'll refer to as intent-based treatment, intent-based treatment definition. So we name things according to the problem they're intended to solve. There's memory remediation. There's gait training. But the implication here, unless it's further defined, is that if a therapist really wants your gait to get better, whatever they do will make your gait better. If a therapist really wants to attack your memory, that desire, that intent, that goodwill is itself therapeutic. And alas, I think probably most of us don't believe that either. And so until we get down to what are you doing in that gait training session, what are you doing in that memory remediation session, we don't know, and we can't define it. And this was very evident to me. I participated last year on an Institute of Medicine panel to look at the evidence supporting cognitive rehabilitation in traumatic brain injury. And an awful lot of the cognitive rehabilitation treatments that we looked at were named in this way. So there might be 10 or 12 studies of attention intervention, but do you want to do a meta-analysis on them when, if you look at the individual content of them, they don't look very similar one to the other? And in fact, one of the prior attempts to synthesize the evidence for cognitive remediation did exactly that. They took all the randomized controlled trials of something called memory remediation, meta-analyzed them and said, does it work? But they included memory notebooks, mnemonic strategies, you name it, a lot of different approaches. Now, you've heard a little bit from Gerben about a piece of the work that's been quite influential in the last decade or so in rehabilitation, the practice-based evidence. which I would refer to, and if I'm mischaracterizing it, I'm happy to have some feedback, but I would characterize this as sort of a refinement of intent-based. That is, it starts with grassroots therapists getting together and saying, we do gait training, we do bed mobility training, blah, blah, blah. But then the discussion continues, well, we have two different ways that we generally do gait training, and it depends on this and that, and here's what they look like, and now we can sort of subcategorize. But still, these are consensus-based discussions, and I think they're not uniformly theory-driven. They're often driven by sort of practical or procedural differences in one form of therapy versus another form of therapy. And so the question that this raises is there coherence to the way in which these subdivisions are arrived at? In other words, when we divide gait training into 2 or 3 subcategories, does that have anything to do with how we might subcategorize some other training in other skill area? Or do we do it from de novo in each new area? Now I'm going to make a case, as we have made in the project that I mentioned, that theory-based definitions are the direction that we should be going in. Consider a patient with limitation in active shoulder range of motion. Do we want to define treatments like ring stacking, putting dishes on high shelves, reaching to targets on the wall? Are those 3 separate treatments that can be used to treat shoulder restriction? And should we do comparative efficacy on stacking dishes versus stacking rings? Or should we abstract from those that the treatment, the active ingredient of that treatment is repeated reaching movements at end range? I mean, we don't need to quibble about the details, but in other words, these 3 things are not 3 different treatments. These 3 things are 3 trivially different sets of treatment materials for delivering the same treatment. And I think this is a particularly crucial issue in rehabilitation because many of our clinicians seeking to engage patients use materials that are patient relevant or patient specific. And if every time you pick a task that matters to the patient, you're delivering a unique treatment that has never been delivered to any other patient before, then we never have any evidence. But if those task variations can be encompassed within a theory about what the crucial characteristics of the therapeutic exchange are, then we can ignore the specific tasks or task materials and isolate the therapeutic ingredients. And this is analogous if you think about mainstream medicine. Do we really want to say that a small red pill is or isn't better than a large white capsule? Or would we want to consider those different molecules that both block beta-adrenergic receptors, and that's the important critical feature. So what are the advantages of theory-based definitions of rehabilitation treatments? Well, a really key issue is that empirical data on efficacy or inefficacy that we collect based on those treatment definitions does more than add or subtract an individual treatment from the armamentarium. It supports or refutes a scientific theory. And my own editorial comment would be that rehabilitation has been somewhat slow to progress scientifically because to a large degree we've empirically compared this treatment to that treatment. And when the answer is it doesn't work so well, you eliminated one of an infinite number of treatments, which really moves us along fast. So it would be really nice if you could prune off a whole branch of the therapeutic tree when you get a negative outcome. So with theory-based treatment definitions, we can be looking at classes of treatments or dimensions of treatment that are supported or undermined by evidence rather than proceeding one by one. But the act of arriving at a treatment theory, and we have certainly in our projects found it challenging. Once you identify a theory of your treatment, it also has the additional advantage of helping inform the question of who are good candidates for that treatment. It doesn't prove who are good candidates, but it sets up hypotheses about who are good candidates, whereas an empirically designed treatment that just is a good thing doesn't have any implications for who would benefit. And it also has very specific predictions for what outcome measures should be responsive to the treatment. What does this treatment really change? Well, then a measure of that thing better show a change. Now, let me give you an example. And, you know, this is the funniest research project I've ever been a part of because we have collected no data. We read articles about treatment, we argue, we write up attempts at conceptualization, we rip them apart, we find a counterexample 2 months later that causes us to have to go back and rethink something that we thought we had resolved. So that's the nature of this work. Fascinating, but frightening if you're used to data that is kind of solid and trustworthy. Anyway, the last few weeks we've been obsessively discussing canes and walkers and other mobility devices. Now, if we approach this from a treatment theory perspective, a cane is a member of a class of objects that reduce weight on one limb while increasing weight on an upper extremity, and thereby, in some way, increase weight-bearing ability. Okay, if we have a theory, now that's a very lame and quickly put together theory, but if we have a theory along those lines, then who can benefit? Does it make predictions about that? Well, would we expect a patient with a metastatic lesion to the femur causing constant pain to benefit from a cane? Probably not, because we're not assuming that in that case the pain is primarily driven by weight bearing. Or, on the other hand, what about the outcomes we might measure? Would we expect that pain ratings gathered while sitting should be responsive to this treatment? Well, it's specifically offloading during weight bearing, so we'd expect that pain reduction during weight bearing would be the most critical outcome measure. So by more carefully formulating how this treatment does what it does and how it does what it does, we constrain both the people likely to benefit and the ways that we would expect to see benefit most clearly. Now, I'm also going to contrast two bodies of theory that we've been thinking about and writing about recently. Treatment theory, which I've begun to discuss, and enablement theory, which I'll contrast with it. So treatment theory, as you gather, specifies the essential ingredients that are responsible for the mechanism of action that changes the treatment object. Now, we've introduced, and in the writings that we're going to be publishing shortly, we're going to have a little glossary because we do have a certain amount of technical language. We've introduced the specific word treatment object to mean the most proximal thing that treatment directly changes by its mechanism of action, and not the many ramifications it might have in the rest of your life, which fall under enablement theory and which I'll talk about later. So treatment object is the specific treatment target that the mechanism is affecting. So the critical thing is that treatment theory does specify how this treatment does what it does, but it says nothing about what the ultimate functional consequences of that are. If I increase your weight bearing, will you get a job? I don't know. Will you have improved quality of life? I don't know. Will you be able to walk? I don't know. Treatment theory doesn't answer any of those questions. Enablement theory, in contrast, specifies the expected ramifications of a change in one functional attribute on other domains of function. And sort of reciprocal to treatment theory, enablement theory doesn't care how that change occurred. In other words, if we have two different treatments that can reduce pain during standing, we predict the same impact on the patient, assuming they're equally effective, in terms of other functional domains. Might be none, might be a lot, but whatever it is, it doesn't matter what treatment made that change. All that matters is how much change was made in that initial variable. And I have joked that this diagram will probably be on my tombstone because I've referred to it so many times, but this is simply a very schematized version of sort of an ICF diagram, although I have not towed the line and collapsed activity and participation or body structure and function, but you get the picture. So the main thing here is that we have multi-causal connections among these different ICF levels. And the reason we need to think separately about enablement theory from treatment theory is imagine that I had a treatment that was very effective in improving your sensory neural hearing loss. Well, can I directly say your language comprehension will improve? Well, no, you may have other reasons for having impaired language comprehension, like a left cortical lesion, for example, and then having the best hearing in the world doesn't make you a great language comprehender. Or if I make an intervention up here, can I assume that if I improve your working memory, you'll go back to driving? Well, no, it depends on other things. So enablement theory has to do with how many and where these different arrows are, and if you will, the relative weighting of them. So hearing may be more important for language comprehension than something else. And so if we had to choose between two things to try to improve to get some distal outcome, we'd pick the one with the higher weight, assuming we had an effective treatment for it. All right, let's go back to the cane. We're going to learn a lot about canes and very little about anything else. So the treatment theory, the cane may or may not increase weight-bearing ability, depending on how much weight it offloads. So we have the primary question of what's the efficacy of this cane in offloading weight. If it's a really flimsy cane, it won't do very well, et cetera, et cetera. Maybe where it's placed, lateral to the body, will affect how much weight it offloads. So these have to do with, does the cane effectively offload weight? And if not, can we make it better in that way? But no matter how much weight the cane offloads, I can't predict it's going to improve ambulation. I got to know whether the person has active use of their hip flexors, what their balance is like, whether they can see where they're going, and so on and so forth. So I can't make a straightforward prediction on ambulation. If they have no endurance, they may not walk even with the cane for that reason. So the point is, when we find that giving a bunch of people canes doesn't make everyone walk again, the next move should not be, let me build a stronger cane. Because the problem is not with the efficacy of the cane with respect to its treatment object. It is with our conceptualization of how that treatment object is related to distal and complex realms of function. And I saw this in a very concrete way when I did an evidence-based review of anti-spasticity drugs. This was many years ago when there were fewer drugs, but I think the story is pretty much still the same. We took published studies on many different anti-spasticity drugs. We sorted them according to patient population, chronicity, age, et cetera, and the intervention itself. And we tried sorting them into piles of it works, it doesn't work. Every way that we tried sorting failed. Didn't seem to relate to population, didn't seem to relate to drug, didn't seem to relate to age, chronicity. When we sorted based on outcome measure used, things largely fell into place. This is a little bit of an oversimplification, but every anti-spasticity treatment works if the target, the treatment object, is reduction of hyperactive reflexes and stiffness, i.e. positive symptoms of the upper motor neuron syndrome. No spasticity intervention works if the treatment object is independent ADLs or mobility. And yet, people keep developing new anti-spasticity drugs, I think imagining that one of them will make people walk again, as opposed to thinking, these are the positive symptoms of the upper motor neuron syndrome. There are some negative symptoms too, like weakness, lack of coordination, co-contraction, et cetera, et cetera. Drugs don't do anything to those. Okay. Now, clinical effectiveness, which is ultimately, I think, what we want to talk about today, gets even more complicated in rehabilitation in this way. We have the usual split between efficacy and effectiveness that has to do with when you move out of the pristine, controlled environment into the messy world, do things change? But we have a different moving out, which has to do with when you want to use this thing to achieve some meaningful functional improvement, do things change? And those are two different things that have to be addressed differently. So clinical effectiveness, first of all, depends on the efficacy of the treatment in changing its object. So if we don't even have efficacy in changing the object of the treatment, it's extremely unlikely that we're going to have something better downstream. But if that is true, then we have the usual question, does it depend on the effectiveness of the treatment in changing its object, still the same outcome, when delivered by routine clinicians to routine patients? Still dependent primarily on treatment theory, just dependent on issues of quality control, heterogeneity in the population, and so on, that we've talked about before. But now, the effectiveness of the treatment in altering distal aspects in the population selected for treatment now depends very heavily on enablement theory. So no amount of optimizing the treatment with respect to its treatment object solves this problem. This requires a different form of research linking improvement in that outcome to other realms of function. Now, I think another important thing we have to think about in this type of research is how much to focus on categories versus dimensions. And I thought about this when Gerben was presenting the data about the orthopedic study in the nursing homes and acute rehab centers, in the sense that that was assessed in terms of categories, SNF, acute rehab, but you also saw that there was a dimension of intensity of treatment. So which of those should we be looking at, or should we look at both together? I mean, because clearly there probably are things that are different about SNFs than IRFs that aren't captured by the intensity dimension. But this is a frequent issue, and I think, for example, in the robotics literature on movement, mobility treatment, and also in some of the partial body weight support, and a number of the sort of physical therapy interventions, it's kind of looking like intensity is maybe the paramount issue, and yet people are sort of putting things in categories and giving them names and comparing treatment A to treatment B. Maybe that's not where the action is. So another way to ask it is, what's the impact of training frequency, number of steps, amount of environmental variation during gait training, and so on. And you can see that at least in my view, the PBE approach still wouldn't have tackled this stuff. In other words, there's very much a categorical concept without measurement of continuous variations within the categories. Now, that doesn't mean, I think that clinicians and practitioners, and for sure billers and coders, need categories. So that doesn't mean that when we say intensity is really what matters the most in, let's say, mobility recovery, that we just say, give a lot of intensity. We can define either optimal settings or cost-effective settings of some of these continuous parameters, and then distill them into the white gait training method, and then everyone will know from now on that that involves many, many steps delivered in a certain way. I hope you will call it that when you figure out what it is. We also have the choice of macro versus micro. So you could study community reentry programs for traumatic brain injury and focus on macro dimensions such as staffing, disciplines and ratio, degree of team coordination, approaches to goal setting. But you can't realistically capture all the elements of all the treatments delivered minute by minute in these kinds of comprehensive programs. So you're kind of pushed to take a step back and capture large structural issues. On the other hand, so you lose something of the microscopic view of what's really going on treatment-wise, but on the other hand, it is realistic to make the claim that a comprehensive multi-ingredient program should have impact on big macro outcomes. So you lose the tail of the specific treatments, you gain a strong prediction of impact on functionally important outcomes, because that's what the program has claimed the ability to change. On a flip side, you could say, well, is conversational skills training using videotaping and peer feedback for TBI effective? There you could focus on, you could even do a randomized control of that versus something else within a comprehensive program and look much more specifically at how conversation skills change and so on and so forth. But you probably can't strongly hypothesize effectiveness for increasing the quality of conversations out in the world. I mean, we've trained both the patient and the partner, that we didn't train the grocery clerk, blah, blah, blah. And then we for sure can't assume that improved conversational skills will enhance community reentry for everyone because there are other obstacles to community reentry. So here we get more granular detail on the efficacy of this specific treatment, but less ambitious claims about what that treatment can accomplish. So what's ultimately required of this effort at classification? I would say a clear treatment theory that specifies the observable or measurable active ingredients. So what are we claiming has to transact between therapist and patient for this treatment to be delivered? And then a measure of adherence or delivery of those ingredients in quantitative terms. So we risk the fact that people say they're doing a treatment, but when you really look at their behavior, it's not very similar to what we anticipate. Once we have both the definition and a measure of adherence, we can look at the relationship between the amount of the defined ingredients that are delivered and the change in one or more functional attributes. So this issue of theory-based treatment definition cuts across observational and experimental research. In experimental research, you need to show that the two groups really got different treatments. They better have different adherence measures. In the observational studies, you probably want to show that amount of treatment ingredients or closeness of adherence to the treatment protocol is associated with differences in outcome. Now, challenges, one more challenge to traditional thinking, but I would hope some compensating advantages, is that we are forced to break up some treatments that clinicians typically think of as single. So we talk often about a long leg brace. That's a treatment, right? But we would think that, first of all, we'd probably like to define that treatment not as a long leg brace, but as a device that increases the force required to bend the knee and ankle. Because that's kind of what it's doing, and if somebody comes up with another thing that does that in a very similar way, we probably would make very similar predictions about who it would help and what it would do. But you can't just hand somebody a brace and then say you treated them. There's picking the right brace for them. So there's the actual selection of the brace and the fitting of the brace to make sure it's the right brace. But the patient has to figure out how to put it on and take it off, or someone has to. And they have to learn how to walk in it. These, we would argue, are actually three different treatments. And why do we need to break them apart? Well, because you can give a very amnestic or cognitively impaired patient the right brace, but you may not be able to train them to don it and doff it, and you may or may not be able to train them to walk in it, and vice versa. So these have different theories of what it takes to benefit from them. Benefiting from training is not the same thing as benefiting from biomechanics. So where is this heading? Just to close and let you know where you can get the truth about treatment in the very near future. Our research group has planned a special issue in the archives of PM&R to roll out multiple interrelated manuscripts as well as commentaries on those manuscripts, some of which will be written by people in this room. Much now depends on the reaction from the field and the work of others to refine and extend efforts at treatment definition and classification. We have encountered many challenges and complexities which will be unpleasant news to the clinical field. The only problem is we think they're really there, and you can't turn away from them. So the question will be, do we get tarred and feathered for turning out something that is complicated and burdensome, or do we get some support for the fact that it really is complicated and burdensome, and we're doing the best we can at systematizing that complexity? Thank you.
John, I have a question. This is Louis Catrano from the NCMRR. One of the questions that I have is to the second to the last slide that dealt with the brace and the three different parts you're calling a treatment. Mm-hmm. I guess the question I have there for doffing the device, for example, you could have a caretaker or someone help you with that. How was that determined as a critical element?
Well, I don't think we're saying necessarily that it's a critical element. That is, if you can invent a way that the brace jumps on a person's leg by itself, then you don't need to give that treatment.
But if you have to teach someone to put on the brace, whether it's the patient or the caregiver, what's the active ingredient of that teaching encounter? And is it the same active ingredient as the biomechanical forces acting on the knee and ankle? No. Braces don't learn to do things. People learn to do things. People have to be taught. Braces have to be constructed with laws of physics.
But given that example, as you mentioned that, you'd have, how would you break out, or wouldn't you break out separate categories of treatment? So for example, the issue is I'm going to put it on myself. Number two is I'm going to have a caretaker do it, or it's a very complicated device, and I need a clinician. I have to go for a visit for it to be adjusted and so forth. I mean, how do you make those distinctions?
Well, you know, I don't want to preview the entire issue of the archives, which, you know, you will be desperate to read when it comes out. But we have so far developed a number of macro theory groupings, what we're calling them. In other words, big bundles of interrelated theory that hopefully will be more finely subdivided. But one of those big bodies of theory is practice-based skill development. So tons of things we do in rehabilitation involve doing something over and over and getting some form of feedback, some form of goal setting, something that tells you what to try to optimize. And whereas far as we know, unless you do it over and over, you can't get good at it. We would view, whether it's the patient or the caregiver, it's still in that category. It's a human being learning a skill by trying it and practicing it and getting better at it. But again, that's different from the treatment ingredient of the brace itself. Now, when you choose to do it with the caregiver versus the patient, some subdivisions that we haven't gotten to will become relevant. That is, if one of them is cognitively impaired and the other is not, there are different training approaches that work better with people who have memory disorders from people who don't. Those are two treatments. They exist in the world. You have to choose which one to give to the patient, which one to give to the caregiver. You could give the other one, and that's an empirical question. But the point is, there would be a form of training that involves fewer errors and less feedback, and a form of training that would involve much more feedback and discussion and try it again and don't do that error next time, you know, blah, blah, blah.
This is John Lurie from Dartmouth. I applaud the effort, and I think you're clearly on the right track that, you know, we should be using theory in the way that we define these things, and the more explicit we can be about those, the more progress we're going to make. But there is a potential downside in that when you sort of have, you know, you say, okay, here's my theory, I think this is going to work like this, and then so that means it should produce this outcome, and I study it and I get that outcome. It's sometimes tempting to think that that has then proved your theory, and you then extend that rather than having proved that specific example. So in a more simplistic form, angiotensin converting enzyme inhibitors were developed because they dilated the peripheral vasculature. It reduced the afterload on the heart, and people said reducing afterload on the heart should be good for heart failure. So they tested ACE inhibitors in heart failure. They found a benefit, and they said, voila. Well, it's clearly true that ACE inhibitors help in heart failure, and it's almost surely true that they don't help by reducing afterload. Mm-hmm. So even when you prove your theory, what you've proved is that instantiation of your theory, and we have to be careful not to allow the fact that we've developed something on theory and tested it to think that somehow that has proved the theory in general.
Yeah, well, I mean, first of all, as we who have taken philosophy of science all know, you don't prove a theory, you disprove a theory. So you only have data that continues to be consistent with a theory until you don't. Yeah, that's a problem, but it's a problem in science. And yeah, we'll develop treatments that we think work for a certain reason, and then they don't work for a predicted subgroup, or they don't work for a predicted outcome, or something that shouldn't work works, and we have to revise. That's the life of science. I would still argue that you're better off having a wrong theory that leads you very clearly to ask specific questions that come up with yes or no answers than say, let's see if this works, which is a lot of, I think, where rehabilitation has been.
I'm interested in whether, in your theory, development, sorry folks, you've thought about short-term and long-term consequences. For instance, in your cane example, you're talking about offloading the hip and the initial benefits, which you could also get from a lateral lean if you're talking about hip pain. Both equally are serving the function of offloading the hip and reducing pain. One, however, has a long-term consequence, that is the lateral lean, that the other does not. So how, in your treatment perspective, do we play in this part of getting the patient to do what you want them to do when in the short term you've got two equally effective things? Is that?
Yeah, I think I get your question. I think that I haven't thought it through fully, but I'll give you a couple of initial thoughts. So first of all, I think there are two pieces to what you're saying. One has to do with sort of the compliance or adoption of things. So there are many interventions that we teach a patient to do with the hope or expectation that they will continue to do them in life in an ongoing way. And a lot of times we're wrong. We think that's actually a critical issue, and we have taken a step in our treatment definition that's a little risky, but that says that treatment is happening in encounters between treaters and the treated, and what happens in the treated's home life is no longer treatment. The reason we've said that is not because what happens in their home life is not important, but it's because you don't have any control over it directly when they're in their home. So what you have to do is figure out how to maximally strengthen the ingredients in your encounter that produce long-term behavioral adherence. And so we feel like by highlighting the fact that your encounter is the only actual treatment, it actually might push you to think more firmly about what those ingredients need to be to have that extended impact. The second issue about sort of what if one way of solving a problem has long-term more negative or more positive consequences, I think, at least in the examples that come to mind or in your example, that would move into the enablement issue. That is, I'm presuming that lateral lean isn't a bad thing in its own right. It's because you're now walking that way for hours on end. So it requires now, it's not just leaning instead of having a cane and standing still. It's having that behavior in the course of many complex activities where you may be taking stress or weight or whatever. So it involved looking at the enablement consequences of two different treatments. Ruth? Oh, sorry.
I have a development question, John. I'd like to know how you think this work that you've all done on taxonomy supports or doesn't support comparative effectiveness research, and whether the progress or the lack of knowledge that we have about what really makes up effective treatments is going to be an impediment to going forward.
Well, I certainly do think it's an impediment to going forward, and I have several times in the last couple years been sort of asked by people who want to go forward, well, okay, I get that that's a big problem, but nevertheless, how will we move forward despite that? And I feel kind of stumped by that. You know, like you can solve a problem even if you can't solve a problem. But I guess I see sort of two different trends helping at the same time. One is we are seeing, I think, more manualized, highly defined treatment protocols being developed. And I think that that's key because a lot of the things we do are complicated, and unless you can get it in writing in a way that can teach other people, it's not going to be analyzable. And then you can say, sessions that use that manual, that becomes a thing, assuming you have adequate training and some sense of at least relative adherence. On the other side, I think we can try to do more theory development and categorization of things that have arisen in a more pragmatic way and try to improve in sorting those. And then in the meantime, we're going to have to do some reliance on the old stuff of hours and settings and stuff like that. So I don't think that there's a short-term great answer. I think these are incremental things. But I know that when we did the Institute of Medicine review, it was a huge problem that we didn't know what the treatments were, and many of them didn't have manuals. And the military is saying, well, so how will we implement this in the system, the things that are best? And with no written guides and no nothing, yeah, how will you implement them? So it's a big, I think it's a big challenge.
Hi, John. Margaret Rogers from ASHA. Kind of a similar question that Ruth just posed, and that has to do with expectations down the line of what sort of outcomes are going to matter to inform policy and payment and all sorts of models of service delivery. In thinking about what expectations are out there for these outcome measures, it seems to me from where I sit that they're much more oriented toward these macro level enablement, what's the final outcome and how are we reducing costs kind of measures. I see very little concern about these more proximal measures, and I think that may be how it's always been. That's the domain of researchers to worry about, whether something's really working, right? And in looking at your dichotomy between the enablement and the theories, I'm wondering if it's really a dichotomy and whether we're going to end up with, okay, you've done 3 parts of this sort of treatment. You've got a different way to bear the weight. You've got a different way to walk with this device on. You have some way of practicing in different formats. And then overlaid on that, aspects of treatment that would work towards enablement. So you're generalizing in different situations and you're planning in the treatment for how this person's life is going to be affected down the line. So I see that this dichotomy exists. It's theoretically very real in my mind, but I'm not sure that when you're looking toward the implementation of treatments and how policy is going to be kind of formed on these sorts of research endeavors, how we're really going to distinguish a whole package that hopefully will end up with somebody, having a better community reentry. So I guess the question is how are we going to really dichotomize this when ultimately what we've got to get to is the end point and it's one package in a way.
Right. So let me first try to clarify something that I think is a misunderstanding or miscommunication, which is I got the impression that you're to some degree equating enablement theory with anything that has to do with more macro functionally important stuff. No. You can, in some instances, treat at the macro level. So when you put a stair glide on somebody's staircase, you're treating an activity. You didn't do anything to their leg strength. You didn't do anything to their balance. You didn't do anything to anything. You just got them upstairs. Okay. That doesn't require an enablement theory about how these lower level things map onto getting upstairs. The treatment was delivered at the getting upstairs level. So when I talk about enablement theory, what I'm talking about is if you have a patient who has leg weakness and balance problems and some visual deficits and hip pain, and you want them to get upstairs and you give them quadriceps strengthening exercises, can you expect that they will get upstairs, yes or no? And we do a lot in rehab where we treat impairments and hope that the aggregate impact of treating a bunch of impairments will translate. That's what I'm saying, is there is a gap that needs to be studied, and it's not going to be accounted for by the efficacy of the treatment for the thing that it's supposed to fix. Right. But I think you've alluded to another issue, which is a big policy issue, which is if you have a short-term view and a cost-based perspective, and you have choices between things that will take longer to achieve but may have better long-term outcomes versus things that can be achieved quickly and cheaply but may not, you know, that's going to be a dicey comparison. And the obvious example that is often talked about is the person with hemiparesis after stroke, that it's a lot faster to train them to dress with their good hand than to see whether you can reestablish function in their impaired limbs, right? Now, I don't think there's an easy answer to that. In the short term, payers will definitely want us to get the person dressed and out of there. We will need to do research to answer the question whether if you spend an extra X sessions doing, you know, constraint-induced movement therapy, blah, 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 will they ultimately have a wider set of motor behaviors that's more flexible, more useful, better quality of life a year from now than if you settle for the short term? And when you get those data and they're persuasive and you roll them out to patients and families and you get pressure, then at some point someone will say, well, that's a quick fix, but it's not really a good value in the long run, if that's the way the data turns out. Yeah.
Okay,
Sorry.
Thank you.
Okay.
Thank you, John. No one ever said this area of research was going to be easy, and I think Tony and John have nicely illustrated this morning not only the complexity but some of the progress that's been made in trying to further some of the foundational work in comparative effectiveness research. And so our last speaker today, Wendy Koster, is going to focus on the outcome side of the challenge. And Dr. Koster is professor of occupational therapy as well as the chair of the Department of Occupational Therapy here at the Sargent College of Health and Rehabilitation Sciences at Boston University. In addition, she's a key member of our Boston Rehabilitation Outcomes Center, heading up our patient-reported outcomes core. So we're delighted to have her here today. Wendy.
Thank you, and I'm the only thing standing between you and lunch. So I hope I can be as engaging and give you as much to think about as the previous speakers have. I want to just take a minute before I go into my talk, because the slide up there is reminding me that I encourage you, if you haven't already seen the materials about the Boston Rock that are around the room, to pick it up and take a look at it, because we are a service to you and are available to you to support you in your work, and we want you to be aware of the kinds of things that we can offer, one of which is consultation around selection of outcome measures in clinical research. So I just want to make sure that you know that we're there and what we can do for you. So I want to go back to the point at the beginning of what is it that, in a sense, distinguishes CER from sort of your usual clinical research. And I think the point that I really want to emphasize is that it is supposed to provide information to guide choices among treatment options. And so that then puts a slant on the selection of outcomes to focus on information that is relevant in a cost-benefit analysis, not only in terms of dollars and cents, but in terms of what will it cost the participant to engage in this treatment option versus that treatment option, and what will they gain for it, and how does that balance look from their perspective. So the outcomes that we are needing to measure have to be translatable into some kind of practical terms like that for whichever stakeholder is making that decision. And I'm also going to pick up on a theme that we've heard, and particularly John just recently referring to, which is thinking along continua rather than dichotomies. That we can be talking about outcomes at the sort of more proximal or immediate, or what what John was describing as sort of the immediate outcome of your treatment and your treatment theory, what it predicts as the outcome, or more distal, less immediate outcomes, which might be those that your enablement model would describe. And often, but not always, going along with this is a movement along a dimension from fairly specific and concrete outcomes to more global or more complex or multifaceted outcomes. And the issue that we grapple with in trying to come up with relevant information is that different stakeholders may be interested in or value different outcomes. So they may be at different points on that continuum. And we've already had some discussions of if somebody's at one point in the continuum, how do we move them along to appreciate something at another end of the continuum? So there are a number of challenges in thinking about the application of comparative effectiveness research concepts to rehabilitation and disability research compared to, for example, the way it was being applied in medicine. One of them is that often proximal or immediate outcomes are more concrete and therefore are easier to measure. So not only is the treatment easier to identify in, say, pharmacological trials, but the sort of immediate outcome that was often of interest was, do you live or die? And that's very concrete, very specific, very straightforward to measure, as are things like days in hospital. If you're somebody on the payer end, and that's a very nice, specific, concrete, very countable piece of data. In acute rehab, we may have, again, some fairly concrete, specific things that are measurable, such as strength, range of motion, or just even very specific tasks that we want to see the person either do or not do before they're released from the hospital, so sit or walk. And for the payers, we've just been talking recently about the immediate cost. How much did those 5 days in the hospital cost? What were the actual charges of that? Those are very immediate, again. We can get them now, and they're very connected in terms of temporal sequence to when the treatment was delivered. However, the goals that ultimately rehabilitation dedicates itself to are more distal and more complex, and those are the ways that often the consumers of services will frame them. And those are, of course, in ICF terms, participation, but even activity is more distal than often the sort of immediate outcome of treatment, or that nice umbrella term, quality of life. So the relevant time period to achieve the more distal and complex outcomes may be long. And that imposes a challenge for us because obviously easier, quicker, immediate, you can add it up soon, you can look at your data quicker, and you can know the outcome sooner. The same goals may be relevant, but additional questions come up. So cost goals are obviously important if you're looking over a longer period of time, but at what point do you stop and tally up the cost? How do you determine when you should be doing that? Which costs should be included? And I think Tony's example was great, and I'm very jealous that you actually had a system within which you could look at all of those different costs, no matter who was delivering them in which clinic, at what time, and so on. And then the question that just came up of, some treatments may show short-term advantage, but no long-term advantage. And over what time period, therefore, do you need to assess in order to determine that? So there are many additional issues that come up in trying to decide what outcome we should be looking at and when. Then the problem that Alan first brought up this morning, the populations we deal with often have a combination of conditions, or they may have multiple sequelae of whatever acute event may have brought them to rehabilitation. I deal with children. They're even more complicated. We've got developmental processes and all kinds of other processes going on. Variations in those combinations may differentially affect responses to alternative treatment options. And as we know, rehabilitation is typically complex with multiple components that may differentially affect outcomes. So how do we incorporate all that into our decision making? So in fact, the selection of outcome measures has multiple things that have to be integrated as we make our choice. First is, who's the primary stakeholder that we're trying to gather these data for? Who do we think needs that information now, or who is going to benefit from the type of information that we're going to collect? What is it that they're primarily concerned with? What is it we are trying to argue with them about, in a sense, or what are we trying to present as a case to them? And what kind of information are they going to find meaningful for that concern? What context will the data be gathered in? And what measures are available? And here, again, we can sort of break it down even more. We need measures that suit the research design. We've talked about differences between an RCT or a pragmatic trial or a observational style. Those potentially are going to involve different types of measures. Measures that capture the relevant outcome, which, as we've just talked about, can vary along quite a long dimension, and therefore we have to determine at what point it's appropriate to capture the outcome. Which ones are suitable to the population, and which are sensitive to change. So I want to talk a little bit more about some of those decisions and how I think that they are specifically relevant in comparative effectiveness research. So to sum up, what, how, who, and when. So first of all, what outcome should be measured to provide useful information if we keep this question of what will help people make a choice? What will help a stakeholder decide among alternative options? And here I'm going to really echo and support John's message of, I think, really spending time on working out our causal model of the processes that are being studied is just absolutely essential. Not only in sort of advancing theory, which we very much need to do, but you can't measure an outcome unless you know what outcome it is you expect. And you can't identify what outcome you expect unless you've really modeled out what's going on in that situation and what therefore is likely to happen. So the mechanisms of action of each treatment, or if we're at the enablement model, I would say even more so, you need to sort of really lay out the broad landscape of what are you doing, what are you thinking it's going to affect, and what other things are playing a role in that, and how is that going to get you to your ultimate outcome. We still need to do more of that. So then, if we've done that, and we sort of feel that we can make a logical case that if we provide this, and this could be very specific, or this could be multifaceted, then we should get that. What measures do we have, and which would be the best match to that outcome? And here, obviously, I've spent a lot of my career sort of trying to provide some better answers to this question, because we haven't always had really good tools to measure the things that we do think we're affecting. One of the things that I think is still being elaborated, the ICF didn't help with its definitions, is how do we classify the different levels of outcome of function and disablement? You know, what is the construct we're trying to measure when we talk about function? How should it be operationalized, and what should we be asking, therefore, in trying to measure it? So, somewhat like the treatment theory, I think we also have to have very clear definition in mind of what is that outcome? What is it that we need a measure to capture? And just saying function really doesn't get us very far. We need to then look at whether there are items that are within those measures that really capture our understanding of that construct, whether the measurement dimension is really relevant as a way of capturing that construct, and then again, sensitivity. So, you know, we've had a habit, I think, in this field of once the measure's out there, we're going to use it. And no matter whether it fits or not, because everybody knows it, we'll use it again. And this is not only in adult rehab, I see it with young children as well. You know, a good example that used to drive me crazy was there's an infant test called the Bailey Scales. And it, for very young infants, really the only way you used to be able to really look at their cognitive activity was ask them to do something that involved some kind of problem solving or manipulation or something. And from that, you could make inferences about their level of cognitive development. Well, hopefully anybody in this room would listen to that and say, well, then if you've got a child with emerging CP that already looks pretty severe, that's probably not a valid measure to use. And yet people went on and on and on and on using studies because everybody uses the Bailey. And so that's, of course, how we look at the outcome, the developmental outcome of a young child who, and then you name whatever the other condition they're assessing. So we do have measures that are out there. And they do say that they're measuring function or daily activity or community reintegration. But does it really address the relevant domains of behavior and experience that we think the intervention we're providing is in fact going to affect? Do the items make sense to persons receiving either treatment? And I've really been thinking about this a lot recently because I have a colleague, Chris Helfrich, who does research with people who are either homeless or very recently housed with severe mental illness. Well, asking them some questions about management of their home if they're homeless is obviously irrelevant. Hopefully it would be one of the things that would change, but you've already set things up in a negative way if you're asking a person a bunch of questions that make no sense to them or that are clearly not asking about a domain of experience that's their current focus. And so the items that we assume, well, it says it's function, it must be relevant, we need to look at. And so along those lines, do they sample the activities or experiences that are relevant to the population that we're asking our effectiveness question about? And then a question that, again, I see people ignoring, I think often to the detriment of the study, is the domain measured separately, or is it one of 6 different domains that are all collapsed together into an aggregate score? Which, again, hopefully you realize doesn't make a lot of sense, but I see being done a lot. And then, of course, you've so weakened the ability of the instrument to capture the change in that one domain that you've been targeting that you've kind of undercut yourself from the very beginning. And these are things that are going on right now. And people are doing that perhaps because there is no better alternative, and that, of course, is one of the things we need to keep working on. What I find interesting is that often when we're looking at instruments, people do know to look at the item content, but they often don't look at the measurement dimension. And yet, part of our treatment theory or our enablement theory should really be able to specify what kind of change is it we're actually looking for. For example, do we expect that what we're doing is going to result in a decrease in assistance needed? Is it going to decrease the experience of difficulty, or is there some other aspect of performance that actually is the one that's being targeted by the intervention? That's a rating scale issue, because if your rating scale is measuring change only in terms of amount of assistance, and you're dealing with people who are already living alone in the community, you're not going to find anything that's changing probably. Again, with participation, the question comes up, if I count the frequency with which people engage in certain activities, is that really a meaningful thing that my intervention would be affecting? Am I trying to change the number of times they go to the library, or am I trying to get some other aspect of performance that's changing? For example, the diversity of places that they go in the community, or the distance they travel from their home, for example. So we need to give more thought to just what aspect of change are we really expecting to be affecting? Because the treatment may affect one and not the other. Another challenge is then to make sure that our measurement scale is going to match the degrees of difference that we expect in the population we see. And our measures are often targeted for certain kind of places on the continuum of function. So, some of our measures are targeted for people who are in an inpatient facility, are functioning at the moment at a fairly low level. They're great for that, but with more and more being looked at in terms of people moving into the community, do we have an equivalent measure or a better measure that would capture degrees of variation in that setting as opposed to the inpatient setting? So this is partly an issue of floor or ceiling, but it may also be an issue of simply just not matching in terms of the content of the items, not being the kinds of things that people are doing typically when they're in that environment. I've had a number of experiences that have reminded me of the importance of the wording of items because they don't match what the population I'm intending to see or use to characterize their experience. So an item that says, since your injury, for example, may be very confusing to somebody who's receiving services after a hip replacement, which was not brought about by an injury, but perhaps by some other condition that made them make that decision. Critical question in all clinical trials, of course, is whether the instrument is likely to capture real change if it occurs. And this, of course, is what we get referred to as sensitivity, or the indicator of the instrument's ability to detect change. And these are several of the ways that we are used to looking at that. Even the issue of sensitivity has to be looked at a little bit more critically, however, because sensitivity is usually evaluated in relation to a time period. And the question is, does that time period match the period of our study? If it's sensitive over 4 months, but we're looking over 3 weeks, that may be an issue. Will there be enough variability in the population? In other words, is our sample diverse enough in the quality that we're trying to measure that we're not going to have restriction of range? And this has been a problem in several studies that I've seen because the wording of the items, or particularly the rating scale, didn't have enough degrees of variation to really distinguish things that we were interested in. A critical question that I think CER has really brought forward more than I've seen in the literature previous to now is the possibility of negative outcomes. That not only do we need to look at which intervention is more effective, but we also need to consider the possibility that there could be negative consequences. And have we included in our design a way of measuring that or of capturing that? It could be that we could be looking for changes such as secondary conditions, but we also could have to deal with the possibility that some people will get worse and incorporate that into our analytic plan, because we often assume when we deliver intervention, everybody's going to get better, but life happens, that doesn't always occur. And have we checked to make sure that negative outcomes have been examined? Often for the client, the weighing of negative outcomes against the relative positive ones is what they're going to need to do to make a decision. So have we documented those? Have we incorporated that thinking into our selection of outcome measures? And then finally, you all know that a significant difference may have limited clinical significance. And so the question is, do we have any information on a given outcome measure of its, first of all, the degree of change that would represent real-world meaningful difference? Now, this brings up an interesting question. Real-world meaningful difference to whom? And how do we go about determining what is real difference? And I think this is an interesting area where we probably need to do more work. There has been some work that's gone on, not typically by rehabilitation researchers themselves, of what would matter most to you, this or that, or various combinations of things. We've heard that the populations we work with are often complex. They typically will have more than one clinical problem. They may also have multiple manifestations of the same problem. How are they going to weigh or weight the different possible outcomes of different interventions? And have we investigated what they would tell us in terms of the relative balance or importance of one thing over the other? So, how important is it to you to be able to get out of the house versus having reduced pain? Or how important is it for you to be able to drive your car versus do some other functional activity? those are the kinds of things that at an individual level, people are going to incorporate into their decision among treatment options, because it relates to their life goals, their important life activities, and which settings are most important to them to participate in. And I think we really probably need a lot more information than we have about that. So, you know, there's this sort of rule, general rule, 10 points of change in this is enough to make a meaningful difference. Well, when you really look at that, a lot of times what it means is it's enough change to actually see something different about the person, but it doesn't really tell us whether the person thinks, you know, oh, gee, you know, going from this level of assistance to that level of assistance really matters to me. Or it's really worth it to me to go through X procedure, or to invest X amount of time in therapy appointments to get to that point. You know, particularly when people are receiving services in the community, and going for intensive treatment requires getting to the place, dealing with scheduling, dealing with all the complications that come up. You know, those are all things that now interfere with other parts of life. How much are people willing to do that in order to get that outcome? Is it enough? Is that change enough that they're willing to do that? And so again, I think that's an area of research that we probably need to attend more to. Who will be providing the outcome information? One of the things that was was a little obvious in discussing the different approaches to treatment studies is the fact that often, depending on the type of study you're doing, you're actually relying on different sources of information. If we're dealing with a treatment that definitely involves an immediate change in performance, there may be one type of measure that we need. Increasingly, though, agencies are asking for information on client or patient-reported outcomes. And so in that context, we're going to need measures that will allow us to gather the information from the person themselves. Or we may need to rely on a proxy. Again, I deal with children, so often I'm getting parent report. Another major source in the kinds of studies we're talking about today is administrative records, where the outcome of interest is cost, or you know, therapist time, or days in hospital, or things like that. So there are a variety of types of assessment, and they have different demands in terms of the resources that is going to be required, A, to get them, or two, to get them with good quality control. And how much you need that's going to depend on the kind of trial that you're running. When should the outcomes be measured? This is, again, where I feel we have to go back to our treatment or enablement theory. What does our theory say in terms of when we should expect to see an outcome of that kind? Is this something that, when it's implemented, you should see the outcome fairly immediately? Or is this something that you expect, according to your theory, that you're going to need a certain amount of practice or repeated instruction before you should start to see the outcome? And if you're dealing with an enablement framework, over what time period do you think you're going to need to wait to see the movement from approved activity performance to, for example, return to work? What is that time period within which we should be measuring? What is the expected trajectory of change plays a role in that. Particularly complicated is the situation where we're dealing with a condition that it fluctuates. So MS, for example, but also conditions where change may occur rapidly. So for a certain period of time, we need to measure fairly quickly, but then there may be a more extended period of time, and over what period should we be looking at? This is where funding becomes an issue, because with those more distal outcomes, we really maybe should be talking a year out to get a full picture of, has the person returned to their previous level of function, for example, if it's been a joint replacement. And then, of course, does this time measure, the time frame that we've established, does that fit with the measure that we're using? So I sort of tried to summarize the thought process that I would say we need to go through, which is really much more of a complex one than even I realized when I started out in this field, probably, of going through a checking process before we end up at selection of the outcome measure. And what I want to call attention to here is there's nothing up here about your standard reliability and validity. That's a given. This is all on top of all of that. And essentially the message is we can't just stop with your standard reliability and validity assessment. There's so much more that has to go into, in fact, having the outcome that's appropriate to measure for the question that we're asking, and that our theory supports. So I think that the choice of measure, like the design, is a really key factor in determining the ultimate value of the effectiveness study. If we haven't asked about the right outcome, we haven't really answered our question. We've compared our two interventions, but on something that in fact isn't giving us the answer that we need to help guide choices. And as I just said, that making the right choice really means going quite far beyond what we would see as standard recommendations for how to evaluate an instrument. We're really talking more about selecting the instrument that best matches your purpose and your design. And that ultimately, we need to be sure that the measure will yield information that's going to be helpful to at least one stakeholder, and always good if you can cover more than one base, in choosing among the treatment options. And that is a very quick walk through outcome measures. So, questions? Tony?
Wendy, that was great. I have a question that's related more to how we can be assured of equivalent outcomes in a comparative effectiveness study. Because I see a lot of the potential of comparative effectiveness research with regard to rehab as comparing a rehab type approach to something that usually is a different approach that carries a lot more cost and a lot more risk. And so I see us in the long run being able to say, well, the outcomes were equivalent, and yet there were much more risk and much more cost to the other approach. And I'm always troubled with how do we take measures, any measure, and I mean, I'm not comfortable with there's no significant difference, therefore they're equivalent in the outcome. And do you have any insight as to how you would address that?
Well, I think, first of all, what we're probably dealing with is measuring more than one thing, because that's going to be a weighing process. To say they're equivalent is to say they did equal good with no significant difference in terms of the harm or the negative outcomes as well, or the negative demands that were placed on the person, whether it's cost or time or whatever. So I think that one of the things we need to do is to shift our thinking just a little bit from measuring a thing to sort of measuring what is the overall that we are checking here. So are we overall saying, are they equivalent in terms of restoration to community participation? Are we saying they're equivalent overall to, or to something more immediate in terms of performance of specific activities? And I think that that's, again, where we have to go back to the model and say, well, what is it we really want to know here? Or what is it the payer really wants to know? Or what is it, who's the stakeholder? What ultimately are they going to value as a basis for making that choice? And I think it is going to involve multiple variables a lot of the time. So it's going to be a fairly complex, for most of the things that we deal with, I think, it's going to be complex. You're the only one who has a system where you can do that. We're looking to you.
So if I take that a step farther, and in many cases, people are using numerous out level, they're measuring at the activity level, they're measuring at the person level. At what point is it measuring just for measuring? And so even though we're looking at the right tool for what we want to ask, At what point are we over measuring? Some are done by the clinician, some are done by the patient. At what point are we truly getting the information that we want? I guess is my question.
Well, I guess I can answer, and maybe some other people have some thoughts. For me, what I've always done is gone back again to that treatment or enablement model, and tried to prioritize. So rather than what are all the things that could enter here, what are those that I have evidence to suggest they're really critical? And if I need to make choices, at least be guided by that sense of, yes, this matters, yes, this matters, yes, this, but this really matters. Because otherwise you do end up just collecting 8 zillion pieces of data that you have no system to organize. And so you end up, in a sense, fishing. But to go back to a model and to say, well, according to my model, these are the things that should be most consistently and strongly related across levels of analysis, perhaps, I think gives us a way of narrowing down that is more systematic, more reproducible, and maybe guides us to say, well, what measure would be the best one to use for that? So that's always been the way I would sort of look at that question.
Hello, I'm Joanne Wagner from St. Louis University. I'd like to ask you a question related to minimal detectable change and minimally clinically important difference, or whatever terms you want to use. But in my area of research, multiple sclerosis and balanced mobility, there are very few measures that have gone beyond the validity and reliability. And if you look in the stroke literature, there's more advances there, but often those statistical qualities or psychometric qualities have been established in very small sample sizes, 20 or 30 people, and then the literature runs with you need a particular change to detect a minimally clinically important difference. Can you speak a little bit about how you think to move comparative effectiveness research forward, how we need to address that problem in different patient populations, and what potential designs we would use to get at that information? Do you think they're important attributes, minimal detectable change, minimally clinically important difference? And how do we address that lack of
Conceptually, I think
information?
they're important. The way they're utilized sometimes I have some difficulty with because they become rigid rules. And it's not clear to me that those rules refer back to something other than a statistical reality. So that's where I say I think we have more work to do do investigations that specifically look at what point, what are the thresholds on the kinds of measures that we have where people say that matters, or that's what I'm aiming for, or that would be, if I could get there, that would be worth it to me to do X, Y, or Z. And to use that, because that may in fact be larger than the minimal clinical difference. You know, people, they say, that's good, but when I consider what I have to do to get there, you know, I don't know. You know, I might rather just find an alternative way of doing it or switch focus or something like that. So I think that in that case, and I don't have expertise in the area. I know that there are designs that involve essentially using the people themselves as some kind of external criterion with hypothetical or real scenarios, and then getting their input in terms of at what point would they trade off this for that, for example.
Like a patient-anchored
yeah,
change.
It's tricky sometimes to figure out where your anchor is, but yeah, I do think that needs to be done, and probably more than once, because depending on depending on what outcome you're talking about, that may shift.
So just a general comment, as a junior investigator in the area of MS, it seems to me that CER, thinking about doing CER is a few steps away from establishing some very solid foundations, somewhat about how you define what the interventions are, or what tools you're going to use if those tools aren't even really established in that population.
Unfortunately, that may be true. Although some people here probably have a lot of expertise of figuring out sort of where's the best place to begin in terms of what will give you the most to invest in that now in terms of your long-term goal. Yeah, you know, my bias is that it's taken a long time for the funders to recognize how important measurement is to this whole enterprise. So where I think we're a little bit behind, we've done a lot of work in the last 2 decades to really develop a better sort of armamentarium of measures. But we didn't get started as early as the clinical trials people did. And so I think, you know, we still have areas where we do okay, and then there are areas that we're not really dealing well with at all, particularly community-based types of success outcomes. Gerben?
So,
oh, over there. Okay, Sally, hi.
I have the mic, so. Thank you, Wendy. That was very interesting. It seems like the implications for CER are that we're going to have to get much more sophisticated, not just about outcome measures, but about measures of our confounders, because we're talking about more complicated research that involves more diverse populations and therefore more confounders. So I wonder if you could just speak to that for a second.
Well, in terms of, I mean, what I understand best about that situation is obviously in terms of outcome measures, because that's what I've worked in. But, you know, I think that, again, I would go back, I always am going back to the model that I'm working from in terms of, you know, who is the population I care most about and what are the most critical elements to define that population, and to work with that in the pragmatic design, I guess, to define the population. You know, it's so easy to get paralyzed by the number of confounders that exist when you're dealing with people with significant disabilities, particularly if they're living in the community where there are all those other complexities, that I think I go back to the model again as a way of defining for me what's really important here. What do I really need to make sure is consistently a feature of the people that I include, for example. In terms of outcome measures, one of the things, again, I think we've been overly slow to deal with, and partly because we're just getting the basics, is the appropriateness of our instruments across the various diverse subpopulations within the U.S. I mean, I talked about example of making sure the activities are appropriate depending on the life situation of the person, but never mind that. What about, are the items appropriate for all the different cultural and ethnic groups? And if, you know, that's not just an issue of being sort of politically correct, but are they understanding and interpreting those items in the way that we are expecting that they are interpreting them? Do they have a whole different meaning? And so when you are looking at results of a study, are they in fact telling you something different than you think it is, because the instrument isn't even the same as interpreted by that different group? So that's going to be something that we need to do, again, more to look at, because I think a lot of times our instruments were developed with more convenient populations, and then we take them to deal with those sort of more messy populations, and we haven't always checked to make sure that they're still valid and understood in the way that we intended them to understand. We haven't done that extra step. Lunchtime? All right.
Thanks, Wendy. Mary, I want to thank all of our speakers this morning. I really found it stimulating. I think it generated a lot of questions and discussion. I hope we can continue that dialogue through lunch, and then Mary Slavin is going to talk about the afternoon.
Again, thanks to all of our speakers and to our audience. It's been a wonderful morning. Really enjoyed it. And now we have a lunch. We're going to say goodbye to our webcast group that are joining us remotely, and the group that's remaining here. We'll have lunch at 213 Bay State Road, Hillel Center. You see a map in your binder, so just head over there. It's on the 3rd floor. We're going to reconvene at 2:15, and we're going to break up into 5 different work groups. 2 of the work groups will come back here, and that's the work groups on cost effectiveness and technology. You'll be back here. 3 groups will stay over at Hillel, and that's the competency group, the mental health, and the trials in action. If you look on the back of your name tag, you'll see a sticker that says where you've chosen to go. And if you don't have anything, come please see one of us and we'll help you out with that. We're all going to be back here at 4 o'clock for a concluding panel discussion with our funding agencies. So wherever you are, we're back here. If you want to leave your things here, it's fine. We have people who are going to be watching the room. The people will be at the registration desk if you have any questions. We also have taxis available at the end of the day. Check with our staff at the desk if you need a taxi, and we'll make sure we have enough taxis coming. I also wanted to point out the purple evaluation form. We hope that you'll complete that and leave it at the registration desk for us so that we can see the kinds of things that you liked about this and what we might do in the future. So again, enjoy your lunch. We're glad to have you here at BU. You're going to get to see a little more of the campus right now.